All right, well, welcome. Thank you very much, and really appreciate your joining us for this meeting of the Bipartisan Commission on Biodefense, and it is aptly called Under the Weather, the Nexus of Climate Change and Biodefense. And this is actually the first time that this group, the Bipartisan Commission on Biodefense, has taken on the issue of climate change, trying to look at what are the biological threat issues related to climate change and how can they best be addressed, thinking about this in terms of the role that many different organizations need to play, government, industry, not-for-profits, international organizations, and of course the importance of cooperation across disciplines, sectors, and borders being crucial to the ability to find meaningful and sustainable solutions to important aspects of climate change. I think, climate change, of course, is one of the grand and urgent challenges before us all. There have been many discussions around climate change-related concerns. Health, I think, has only recently begun to emerge as important aspect of the discussions, both because the health impacts of climate change are really vast and significant, but I think also because health is something that matters to us all, whatever your ideology, whatever your background, whatever your national identity. And the health aspects of climate change are profound and are being felt by us all now, whether it's infectious disease threats, including pandemics, but also changing patterns of disease, or it's aspects of extreme weather events, floods, droughts, hurricanes, fires, that is being felt in ways that matter to people now. And as we learn more, as the science and understanding advances, we are also recognizing that the impacts of climate change and the secondary effects are much broader than we had ever really understood. Many people think, for example, of air pollution as related to climate change, and of course it is, but that it's a respiratory problem, maybe with some heart disease-related issues. But it turns out it has impacts on child development and infant health. It turns out it has impacts on dementia, and other organ systems, of course. So I think we're beginning to understand that the health impacts of climate change and climate-related events and environmental degradation are profound, cross the lifespan, and also cross geographies and socioeconomic status, et cetera. So I think it's such a galvanizing issue. It's such an important issue. And I think it has been under-addressed, and we're very fortunate today that we have some of the really terrific thinkers and actors on issues of climate change and health with us today as we think about and learn more about the relationship between climate change and biological threats, and recognizing that there are huge impacts on health, which I've talked about, also huge impacts on economic security and productivity, which also are linked to health concerns, and on our national and international security. And all of these things need to be brought into our thinking and our actions. The Bipartisan Commission on Biodefense, I think, has a long history of leadership in the area of addressing biological threats, really digging deep into the evidence and what is known and trying to come up with actionable steps that can be taken. Large focus on what government can do, but broader as well, generally with a more domestic focus, but also recognizing that many of the biodefense-related threats before us have to be viewed and addressed in a more global context. So I think this issue really does require us to think deeply and broadly to think in terms of what actions can we take now and what is needed for the longer term, and how can academia, government at every level, the private sector, international organizations, and civil society come together to make a difference. So we're very excited. I want to also recognize that Donna Shalala, the co-chair of the commission, has just arrived in off of the train. And I also recognize that people will be coming in over the course of the meeting. It is cold out there, and it's a complicated city to get around. Also, with regrets, the governor couldn't join us. She had originally planned to participate, but the press of events in Albany, I think, have kept her from us. So that's a disappointment, but we're very fortunate to have a kickoff speaker and presenter who has broad experience and a lot of really important ideas about what needs to be done and how best to address the concerns before us. But before that, I want to turn to my longtime friend and colleague, Jim Greenwood, who is co-chairing with me this particular meeting of the commission, for some opening remarks.
Yes. All right, well, thank you, Peggy, and good morning to everyone. Thank you for coming. It's a pleasure to welcome you to this important discussion on the intersection of climate change and public and One Health. With shifting ecosystems that provide new breeding grounds for disease-carrying vectors, to changes in temperature and rainfall that affect the spread of pathogens, the connection between our changing climate and public health is quite evident. This intersection calls for collective expertise to lead to a comprehensive approach. Today, we will explore how the global challenges are linked, the analyses behind these emerging threats, and most importantly, the strategies we need to consider and implement in response. My hobby is bird photography. My daughter calls me a bird nerd. I photograph birds on every continent, and this time last year, I was in Antarctica photographing birds and other wildlife and witnessed the death toll among penguins and many other bird species, as well as among marine mammals. Birds, seals, and whales are already suffering from the decrease in the populations of krill, which is critical to their survival. Global warming is decreasing the habitat for krill as they move toward the South Pole in search of colder water. I served for 9 years on the board of the National Audubon Society and learned that 2/3 of bird species in all of North America may be vulnerable to extinction if global temperatures rise more than 1.5 degrees Celsius. As bird species move northward to get to the warmer climates, the colder climates, I should say, they can carry viruses into habitats where they were not previously prevalent. Earlier this year, we held a hearing about air quality. Today, I look forward to learning more about how worsening air quality due to climate change impacts the health of and disease in animals and vegetation. We have a distinguished group of experts with us today, and I'm excited about the insights and the solutions that will emerge from our discussions today. Look forward to co-chairing this meeting with you, Peggy, and analyzing where the Commission can play a productive role. And I yield back.
Thank you very much. And Donna, can I now turn to you?
Yeah, I think I'll pass Peggy. We have a very distinguished visitor who I've been admired over a long period of time, and why don't we go ahead and hear from Dr. Kerry?
Okay, I think first I just wanted to let the other commissioners make, I believe that Governor Ridge is not with us yet. He'll be joining us, and I believe Senator Daschle will be joining us later as well. So, and I'm not sure whether we just talk. I don't see a button that works, so I think you just talk.
Are these just live mics? Oh, good. I'm so glad. No. I'm Fred Upton from Michigan, and it is a pleasure to be here. Thank you, Peggy and Jim, for your work on this. It looks like a very distinguished panel. I don't have prepared remarks, but I know that this is such an important topic. All of us on this panel believe in climate change. It's real, whether you're Republican or Democrat. Jim was in Antarctica last year. This year I was in the Arctic. We saw firsthand the icebergs that aren't there, the calving of the glaciers into the water, the impact on polar bears and birds, and so many things as we traveled the coast of Svalbard to the north, where Susan and I were a few years ago as well. Last year in New York, I was here on a couple different occasions, and they had glorious sunsets, but that was because of the fires in Canada, literally more than 1,000 miles away. We saw the same thing in Michigan. I came from Michigan yesterday. We had a really terrible snowstorm, blizzard, lots of accidents. Schools are closed today. Lucky that I was able to get out before the storm. But one of the reasons this cold spell came down from Canada, but Lake Michigan is about 10 degrees warmer than it normally is. And because of that, that lake effect snow comes and just dumps snow in no visibility. So, we see what's happening, and we also know how it impacts not only the food supply with, terrible things like ticks, mosquitoes, malaria. I know we're going to talk a little bit about that today. Climate change is real, and we have to figure out how we're going to deal with it, and because that's what we're here for. So we're going to appreciate your testimony this morning and the other panelists that are here as well. And with that, I yield back. Thank you, Peggy.
Great. And Representative Brooks.
Good morning, everyone. I'm Susan Brooks from Indiana, and completely agree with everything my colleagues have already said. But one thing I'm just so pleased about, that the Commission is focused on the health aspect of climate change. We often focus, and the media focuses so much on whether it's the fires, the hurricanes, and the devastation, but we rarely hear about the actual health impacts of those disasters. And I think it's critically important for our group to hear from these incredible experts we're going to have today with their ideas, with their solutions, with the strategies, because that's what the Commission does. We will take your ideas and we will incorporate them into recommendations that we then provide to members of Congress and to the White House. And hopefully to local officials as well. And that's what I started my career in local government, and I love that we have local, state and federal officials that are here to share their ideas on strategies that work. And we have to raise the attention level to what the health implications are of climate change. So thank you, everyone, for being here. Look forward to getting this started.
Well, thank you so much, and I think we are, all really quite excited about this focus for this bipartisan commission. Tried to put together an agenda that could address some of the critical issues, looking at the link with health, looking at One Health and the intersection of animal, human, and climate change issues and health, looking at some of the less focused on issues of how climate change will affect, big concerns like migration of populations that are fleeing because of drought and food insecurity, or in response to extreme weather events, and also looking at the national security issues. Frankly, we had many topics we wanted to try to cover, and many speakers that we wanted to bring in. We think this will be the first of a continuing effort to look at some of these issues and follow up. But we are so delighted to be able to start with Dr. Vanessa Kerry, who really has been a pioneer in the area of climate change and health. She has her roots in medicine, and has done remarkable things in global health, trying in particular to build capacity for access to critical health services and strengthening health systems in some of the poorest countries in Africa, but also putting her intelligence and her passion and commitment to working more broadly on issues of medicine, public health, and now really a leader in climate change and health, and on issues related to how climate change, health, and security all are intimately intertwined. So I don't think I was the person that was officially supposed to introduce Vanessa.
Was, but you did a
But
very
I
good
got
job.
carried away because Vanessa, I also consider to be a friend and colleague, so, but Jim, the official introduction.
So, again, thank you for being with you, and as I said earlier, I'm a big fan and friend of your dad's. So, Dr. Kerry is a special envoy for climate change and health for the World Health Organization, Chief Executive Officer for SEED Global Health, Director of Programs in Global Health, Global Public Policy, and Social Change at the Department of Global Health and Social Medicine at Harvard Medical School. Otherwise, she's just goofing off. And the floor is yours.
Thank you very much for having me. I'm also a mother of two, which I
Yeah,
think
I was
is
gonna add
probably
that.
one of my most important titles. Thank you for inviting me today, and you have introduced me, so I don't need to really do much more other than just to add that I have spent a lifetime as a physician too at the Mass General Hospital, in addition, and have recently taken up a position now at the Harvard School of Public Health to lead their global health and climate policy initiatives there. I'm incredibly honored to address this commission and to be invited to do this. And I want to recognize your leadership in advancing policies to prepare the United States for biological threats. Your mission is more critical than ever, especially as we face a convergence right now of challenges that are threatening our health, our security, and our overall resilience. You've already said it. Climate change is no longer a distant threat. Whether you choose to acknowledge it or not, it is here, and its impacts are accelerating. Global temperatures are at their highest as they've been in record history. Extreme weather events are more frequent and more severe, and ecosystems now are changing faster than predicted, which is disrupting biodiversity and resource availability. And these shifts are not abstract. They are deeply felt in our health and our well-being. Health is the lived experience of climate change. And so climate change is not just an environmental challenge, it is truly a human health and security challenge at every level, a human security challenge. The extreme weather events and rising temperatures, shifting disease patterns, and subsequent migration are creating unprecedented threats to public health, to economic stability, and to our national security and global security. If you just consider the cascading effects of recent hurricanes in the United States, where we thought a coastal hurricane wouldn't disrupt our entire IV supply chain in a way that has led to rescheduling of surgeries and disruption of services for Americans. We've had devastating floods globally in Valencia, where you just see thousands, it happened in Derna, for example, in Libya a couple of years ago, that are all related to climate change, where you see thousands die. You lose workforce, you lose capacity in those moments, and you lose stability. And the response and the failure to respond of governments is often then politically destabilizing to those governments themselves. But these events are not isolated occurrences. They're really representing a pattern of escalating risks with direct and indirect health impacts and implications. The evidence is clear. The WHO, according to WHO, 1 in 4 deaths globally is actually from a preventable environmental cause today. And today, air pollution is responsible for more than 8 million deaths a year. That is more than in the entire duration of the COVID pandemic we're seeing annually. And these environmental shifts that we're seeing are compounding already existing health challenges that we were already facing, right? So in addition to the rise of infectious diseases that we're seeing, and preventable deaths that we have failed to stop globally, we're now seeing rises of non-communicable disease, shifts in vector-borne diseases that are moving and compounding existing problems. We're seeing increases in injuries, heat-related illnesses, and fatalities. And all of this, and the changes in temperature that we're seeing today, with the changes in humidity and the changes in air quality, are actually leading to a change in geography of vector-borne diseases, whether it is mosquitoes, whether it is tick-borne diseases, and we're seeing millions of people be placed at risk. It is actually thought that about 4.7 billion people will be at risk of malaria and dengue by 2070. That is the scale we're looking at. That's over half the world's population. Cholera outbreaks, something that we think of as being an old disease, is now happening at increasing rates and amounts, with more outbreaks around the world than we've seen in modern times. And we're seeing it in areas that are most in regions that are very vulnerable already. So these are compounding these regions' vulnerability, shutting down schools, shutting down businesses. Governments are failing to travel because they feel they need to stay home and manage the emergency. So countries like Zambia that spent, 2023 restructuring their debt and going through huge efforts with the IMF and the World Bank are now totally back to square one as they're encountering the largest and longest cholera outbreak they have seen after the result of a series of tropical storms that have come over the continent. And for our work at Seed Global Health, where we partner with governments in sub-Saharan Africa, we are seeing this firsthand. I got into the climate change and health realm because our partners and the workforce that we were training in sub-Saharan Africa were seeing making their work was getting harder. Not 2 patients to a bed anymore in malaria high season, but 8. And so the reality was we realized that our investments were going to fall behind if we didn't start to tackle this intersection. Climate change is exacerbating maternal and neonatal health outcomes. So it's really, we're seeing increases in risk of stillbirth, miscarriage. Women in high heat are still being forced to work, and then they're delivering. And the cascade of that for these children that are born premature is a lifetime of downstream effects and socioeconomic disadvantage. From a One Health perspective, which you will hear about later from a panel, we are seeing environmental degradation, including deforestation, is increasing, promoting zoonotic disease spillovers and increasing the likelihood of pandemics. Paper came out in the last year or two that actually said there's probably going to be up to 4,000 possible crossover events between animals and humans by the end of the century. That will increase our risk, and we're seeing the first cases of bird flu, as you know, erupt around the United States now. But the reality is these changes are going to strain our health systems worldwide. We saw this in COVID. COVID was a canary in the coal mine for what we're going to see from climate change and health. Over 90% of countries had disruption of services in COVID. We are just going to see those health systems be taxed continually as these burdens of disease rise. So all of this is to say that not only is our response to climate change critical to our health security, but it is our security writ large. The security threat we face lies not just in the direct health impacts, but within broader impacts that have significant ramifications in our health, or which are being driven by poor health. The climate and health nexus undermines the fundamentals of our human security. Climate-induced migration is a growing trend. By 2050, as many as 216 million people will be internally displaced, and we're expecting up to 1.2 billion that'll be forced to migrate around the globe. These movements often lead to overcrowded living conditions, increasing risks of infectious disease, and overwhelming health systems in both host and transit regions. But what is oft overlooked or underestimated are the profound security concerns related to our economic stability that come from poor health, whether microeconomic or macroeconomic. Climate change compromises livelihoods, particularly for the billions that work outdoors or in sustenance industries like farming and fishing. We see or rely on natural resources. Poor health from extreme heat or the health impacts of air pollution, which is very related and interlinked to climate change. It is worsened by climate change as well as co-emitted by those greenhouse gases that are driving our climate change, are costing our economies billions annually. Air pollution costs the globe over $8 trillion currently. And the World Bank estimates that climate change is going to drive more people into poverty, with 1/3 of the millions being driven in, hundreds of millions being driven into poverty being directly related to the health effects. So what we're seeing is a vicious cycle of increasing inequity, insecurity, and destabilizing societies. And we cannot afford the cost of this inaction. So I want to bring forth just 3 recommendations for today that are very difficult, frankly, to boil down to all the things that we need to do. But the first would be to invest, really to change our investments away from disease, vertical silos, but to invest holistically in resilient health systems, including prevention, public health, and the social determinants of health. We must strengthen health systems to manage the cascading threats from climate change, pandemics, and emergencies. This includes a series of critical investments, including building an adequately trained, well-distributed workforce from the community with referral chains to the facilities. We need to adopt One Health approaches and understand that our health is deeply linked to the health of the planet, its animals, and our ecosystems. And this is true whether we're talking about the United States or abroad. Core areas of focus have to shift also not to disease treatment, but also to disease prevention. and to primary care to address existing and growing burdens of disease, for example, non-communicable diseases, which are the leading cause of death and disability globally already, but are being exacerbated rapidly in the setting of extreme heat, air pollution, and changes in our access to food, water, and other resources. We also need to, this is really critical, is that we have to invest in innovation, research, and development capacity of the United States to maintain its independence, mobilize our tradition of scientific expertise and technological capacity, and ensure the mobilization of our ability to mobilize independently in emergencies, but also be a global leader in this. We cannot keep importing our talent, our innovation, and other scientific expertise from abroad, or cut our national research budgets without endangering our security. And we must invest in our public health systems. We saw the failure to invest in public health systems and how that led to the spread of COVID rapidly, such that we were one of the worst hit countries in the world in the setting of COVID. And finally, equity. It is time for us to think about understanding that investments in equity actually are our political security, they save us money, and that it is a critical underpinning of reducing the kind of dissatisfaction, anger, and misinformation that we have seen dominating our political system and dominating much of the unsettlement that we've seen. And there's actually data that links that economic inequality as it rises correlates with falls of state or changes in government. We need to mobilize sustainable financing for health. We have to close the $10 billion annual funding gap for pandemic preparedness alongside the $11 billion gap for climate adaptation and resilience of health systems. Many of those investments are the same. These are not different conversations. The investments we make in pandemic preparedness are the same as we would make for climate resilience, or the same as we'd make for universal health care or our primary care systems. And yet we think of these as different, and so we're often competing against ourselves when we could be making single, holistic, whole of health investments. Finally, at the most fundamental level for our security is the need to focus on a just transition and mitigation. The US is the second largest emitter globally of greenhouse gases and the largest historic emitter throughout time. Globally, the world is subsidizing fossil fuels to a tune of $7.1 trillion, even in a setting where we're paying for $8 trillion in the costs of air pollution. We are our own worst enemies. We can spur transition through the private sector, government, and driving funding with clear metrics and accountability, but if we do not address the root cause of this problem, we are continuing to make ourselves insecure every day. We are augmenting the challenges we face against China for energy access and our ability to drive the innovation and have the markets for clean energy and clean technology. And all of this goes back to our individual security, but our ability to invest in the mitigation will not only protect our health, but it protects our overall well-being. To conclude, the opportunity before us is immense. We have the tools, knowledges, and resources to act. And by prioritizing health as a core component of climate resilience, we can safeguard lives, strengthen economies, and build a safer, more equitable future. I urge the Commission to step in and lean into this moment despite all the precariousness of it, to integrate climate and health into biodefense strategies, and to be a vocal advocate for the kind of changes we need now. Your bipartisan approach is going to be crucial to aligning health, climate, and security policies and ensuring that these challenges are addressed collaboratively and comprehensively. By placing health at the heart of our response to climate change, we can really, I think, redefine a future that is no longer defined by crisis, but by resilience and opportunity, move out of panic and neglect into one where we are truly investing in our overall security and well-being. Thank you.
Well, thank you, and excuse me. Thank you, and that was brilliant. We appreciate it very much. I think clearly those who are informed on the issue, I'm sorry. Those who are informed.
Better bring the milk home.
Who you endorsed?
No, I will not serve in the cabinet. Later. Those in the country and the world who are informed about this issue, agree with everything you said in terms of defining the problem and defining the solutions to the problem. obviously, the difficulty is that, at least in this country, and at least for the next 4 years, it looks like there's not going to be support. There won't be an acceptance of the criteria you just described in terms of the reality of the problem, nor will there be a political consensus for the solutions you described. So, and this is outside of your field, I suppose. It's a political question, but I think you know some politicians. What do you think it's going to take to build any kind of a political consensus in this country? In other words, I mean, the agricultural community to which you referenced, it doesn't seem to have been weighing in at the federal level. The fishing industry is not weighing in the federal level. So I don't know if you have any thoughts about how it is that a coalition can be organized that actually change the politics in this country, because we don't have 4 more years to wait for the next administration, the next Congress to act. And do you think that maybe what we need to be looking at for the next several years is trying to get things done at the state level rather than the federal?
I think you're asking the critical question across any number of sectors, and I will do my best to try to answer that question in what I have gleaned. I think that, look, language matters right now. And at the end of the day, I think we have recognized that we are facing increased frequency and severity of extreme weather events. And we have to build an adaptation and resilience to that. When you see the pictures of Tampa General Hospital putting up its giant see-through barrier and the water level is 10 feet high behind it, and the measures that we're having to go through to protect our health system and our services, you look at what happened at the Baxter plant in North Carolina, there's just undeniable disruption of services in a way that we do need to think very pragmatically about how we can protect them. So I think the adaptation and resilience argument is potentially a little bit easier just because I think constituents are feeling it and there is invested interest for governors and others to be involved in that. I do think that the path forward, I think there's great power to working with governors and on a very local level and with mayors and with others, because they, interventions are always more sustainable when they're localized, because there's a context and there's usually community buy-in and you have more ability to kind of engage people with what they need, what they want, and what their worries are. And so I think there is going to be the ability to build a coalition with mayors and with governors and to be thoughtful about the language we use to kind of present that we're ultimately trying to protect the safety and well-being of their constituents. But I also think the power in this is the ability to start to talk about health, not just as a social. We actually measure the cost of health as a non-economic cost in our loss and damages in climate and health. It's an economic cost. The U.S. is losing $100 billion to extreme heat right now a year, which is projected to go up to $500 billion in the next decade or so. Really, that's because it's too hot to work. It's too hot to work because people are getting heat stroke. They're having heart attacks. They're getting hypertension. They're getting dehydration. Those are health issues that we're living. Half the U.S. workforce currently is being impacted by the health effects of climate change. Only 17% of CEOs are paying attention to that. So I think, again, if we recognize that there's still a lot that we can do in this moment, if we are really, but it's about putting it into the language, the terms, and the understanding that people care about and their mandates are in a way that they understand, right? And I think that if I've learned anything in watching, my lifetime of watching politics and what's worked, it's about finding shared value. We all want food on the table for our families. We want the cost of milk to go down, but when you are having hypertension from salinization of coastal water supply that is causing you to have to pay more for drugs, or you're not getting covered for insurance because the rising costs in America for healthcare are going to go up with the increased demands, that is just paid out to the pocket and the inability to go get your groceries. So I think the more we can make these linkages about the fact that these health issues are very real for livelihoods, are very real for productivity and GDP, and are very real. There's a great power to being able to potentially make the kind of shifts that we need right now, regardless of where the federal politics are. IRA, though, I know there's a big desire to repeal it, but billions of dollars are going to red states right now in a way that is creating jobs and actually being an economic stimulus. If they want to shoot themselves in the foot and remove that, that's a shame for the American people, actually. And what we can do is hopefully those of us in academia and elsewhere can help measure the co-benefits that have happened from reducing the greenhouse gas emissions in those communities in a way that people realize, you know, they're doing better. Examples also are, you know, if you aren't going to the emergency room anymore for asthma because you no longer have diesel or, you know, you have gas buses going through your communities, those are days at work you continue to have, days your kids go to school. But I think sometimes we may need to just shift a little bit how we're talking about these health benefits and making it more real and more tangible on a household level, for governors and on local levels. That is the only strategy, not the only strategy, but that is the strategy I think that is very powerful right now, can speak across cultures, can speak across politics, and frankly, is fundamentally true.
Thank you very much. And one would think that the casualty insurance and the health insurers would be weighing in based upon the expenditures that they're making as well. And with that, I'll turn it to you, Peggy.
Okay. Well, thank you so much. As Jim said, that really was a brilliant overview, and I hope you might be willing to share your remarks with us because you had so much substance in what you had to say and as you were answering the questions. You know, your last response, you know, did make me think for the commission, this isn't so much a question for you, but a comment to the commission, is that, you know, we need to be taking very seriously who our audiences are and how we present, you know, the work that we do in this area, because some of our important partners, you know, may be the business community and others who we don't normally reach out to in such a direct way, but it is so important that that information be presented, as you say, in a way that is meaningful and addresses their values and concerns. But also, you know, we do tend to mainly work within the government framework, and we know we need to move beyond. I wanted to talk to you a little bit about your role with WHO and you know, how you feel progress is being made. WHO has certainly been quite powerful in articulating climate change and health as a priority, but do you see that translating into programs and activities? And do you see other countries, and including where you're working with the SEED program, really galvanizing around this issue as health related to climate change, or is it just, you know, a desire for more health capacity?
Those are terrific questions. So I think the WHO has done actually a very extraordinary job at starting to position the importance of climate and health very centrally into global conversations and prominence. The WHO was a leader in bringing the first ever Health Day to the COP28 proceedings, and worked with the COP29 presidency to integrate health across its larger agenda and looking into COP30 in Brazil. They have been part of just announcing a coalition of the 5 COP presidencies from 26 through 30 to actually really solidify and codify health permanently into the climate discussions. And the entire global program of work for the next 4 to 5 years is actually going to be centered around climate change, really centrally, because at the end of the day, climate change is accelerating all the health issues that the WHO cares about and is working towards, whether it is UHC, NCDs, maternal child health, gender equity, conflict. All of this is being exacerbated. I mean, we forget that some of the environmental conditions and drought preceded some of the conflict that happened in Syria, you know, almost a decade ago. So these things are very interlinked. And so all of the issues the WHO cares about and is pushing for are being driven, accelerated, and or progress lost by climate change. And so they have been, I think, quite strong on leading, and they're working to really integrate across their departments to understand how this, you know, basically to help bring climate into every division. And Dr. Tedros and Maria Nero, who runs the Department of Environment and Health, have done, I think, an incredible job, have been tireless in really bringing this forward. And now there's an effort also actually to lead on bringing forward the fact that climate and health is a defense issue. It is a security issue. Dr. Tedros and I spoke about this at UNGA, and we're going to be bringing this to the Munich Security Council because it is critically important that people understand this is undermining people's health, well-being, and the stability of societies and economically. You know, our partner countries and the ministries of health are completely overwhelmed by the climate and health ramifications that they're seeing, whether it is drought, whether it is changing habitats leading to Ebola outbreaks, whether it is cholera that has hit Malawi and Zambia at horrible scales lately, salinization of water in Sierra Leone, and you know, increasing risk of populations. Climate and health is a top health priority in all of the partner countries that we work in, and I would say across much of the sub-Saharan African continent, which actually feels the massive impacts of greenhouse gases and climate change, despite being responsible for only 3% of the greenhouse gas emissions. And it really, the continent as a whole tells the story that is true whether we are talking in urban or rural America or around this country. Globally, those that are most vulnerable already are even more vulnerable to the changes of climate because they don't have the resources to adapt or build resilience, or they live in heat deserts, or they're reliant on you know, outdoor work or sustenance, farming, and other things. And so we're seeing that in Africa, and it's very real. So the countries, yes, they want to advance the strengthening of their health systems, but they're not using climate and health as a mask to make the health investments they want. Those two things truly are one and the same. Because what we're seeing, again, is that climate change is accelerating every single health parameter you know that we could ask for. It's driving NCDs, it is changing vector-borne and communicable diseases, it is changing maternal health, it is increasing mental health burdens. We don't even talk about mental health already, but it turns out when heat index goes up, and there's actually increases in suicidality and emergency room visits for mental health reasons that are very related. This data has come from Australia, Switzerland, and elsewhere. So investing, we can knock off those diseases in silos again, or we can say, my gosh, not only do we have existing burdens of HIV, TB, and malaria that we haven't totally tackled, not only are women dying at absolutely unacceptable rates from, you know, childbirth still in this world today, but now all these things are accelerating climate change. It turns out that if you invest in resilient health systems, and I would argue the health workforce is one of the most important, you actually get an incredible return on investment. Seed Global Health, for example, has partnered to train emergency medicine physicians in Uganda, where over half the deaths in the country are from a failure of emergency and triage services. When Ebola broke out, our emergency medicine physicians ended up training 4,000 healthcare providers around the country when there was no vaccine available, but those healthcare providers provided a ring of defense as people moved around to be able to identify, triage, and quarantine patients so it didn't spread. When cholera hit in Malawi, family medicine physicians who were helping to train in Zambia and Malawi can care for 80% of problems in the community, health problems in the community. And they were able to respond to the cholera outbreak and help lead in responding to cholera. So whatever the disease is, strong, resilient health systems are our ability to counter. We also know that we're going to have to increase that capacity because COVID told us so. Again, 90% of countries had disruption in healthcare services. We are seeing rises of polio, measles, diseases that we thought were close to eradication are now on the upswing. Now, it's a little more complicated. There's misinformation. There's other pieces that are coming into that. But at the end of the day, the disruption of vaccines is very damaging, and cancer diagnoses and others. We have to shift to prevention. It costs far, far less than it does for us to respond.
Donna.
Yes, other than your kids, what keeps you up at night? Is it mosquito-borne illnesses and the lack of preparation by hospitals? Would you talk a little about that?
I'm happy to talk about it. I think those are two separate answers. But to start about mosquito-borne illness is certainly an issue globally because we're seeing that as one of the chief vectors that is shifting globally in the setting of changing temperatures and changing climate. As I shared, 4.7 billion people are expected by 2070 to be affected by dengue or malaria, and the costs of that are actually quite severe. We already spend about $95 billion currently on big the Aedes mosquito health effects, globally currently. And so that is a big issue. It's less of an issue in the United States, though. I think it's worth noting, while we are going to see changes in dengue and malaria, we just had cases of transmission of malaria, obviously in our southern states. On the whole, there's only about 2,000 cases of malaria in the United States, and the vast majority of those are actually from travel. And then the biggest mosquito-borne illness that we see in the United States is actually West Nile virus, and there's about 2,500 cases a year that we see of that. Now, that's quite deadly, so we don't love it when people get that. But mosquito-borne illnesses are a problem, but they're not, at least for this country, that is not our chief issue right now. Our chief issue is heat, air pollution, are the primary ones. But I would say, the thing that keeps me up at night is actually just our failure to understand the fundamental need for health for everything we do. It's fundamental sort of underpinning of our economic well-being. When someone in a household gets a non-communicable disease, 25% of households face catastrophic costs that can put them at risk of falling into poverty. We know that when it's cancer, 50% of households can face catastrophic costs. Data in Africa tell us that when the main breadwinner of a household dies of HIV, 2/3 of households have an 80% decline in income, 60% of households have to move to cheaper housing, 40% lose access to clean water, 20% of girls stop going to school, and 17% of boys stop going to school. There is lifetime impacts that happen over that case. So we have failed as a society throughout years of, I'm not going to get into the history lesson here, and you know better than I do, that we have just not valued health for what it is, which is actually a fundamental of our human security, whether it is our ability to care for our family, to go to work, or our security in terms of migration, disease prevention, and our ability to live, healthy and well. And I think that has to change. Now, I'm going to be very pragmatic. I am driven in the school of equity and healthcare as a human right, but we have decision makers globally that are driven by economics and security. So we should be very pragmatic to translate the reality of the global public goods we need in health into economic and security terms. It's very possible. There's infinite amounts of data there. But that's what keeps me up at night, we are seeing inequities grow. We are seeing consolidation of wealth in the world today. We are seeing more political upheaval. We're seeing more untruth and manipulation of information. And I don't know how you solve the major crises we're facing if you can't find the common ground. So I think we have to be very carefully about where there is the ability to find that common ground by finding the common language. And that is very feasible in the climate and health realm, but we need to be strategic in how we do it.
Thank you.
Fred?
Well, thank you again. An extraordinary testimony and really showing the linkage. I want to talk a little bit about on the prevention side for just a moment. Donna and Susan helped me when we were able to pass the 21st Century Cures Act back in.
About me.
Well, but you didn't vote for it. You helped. She was a major kingmaker for us. Lots of roundtable conversations that she participated. But I meant to say, if I could rephrase my words, people that actually voted for it in the Congress included. We wish you had been a member then, but we had 3 votes here, and we big time with the FDA to make sure that we could actually get the approval of drugs, expedite the approval of drugs and devices. But we also coupled it with $40 billion more in health prevention, health research dollars. It was the last bill that President Obama signed into law, of which Peggy got a pen. She was there. And Joe Biden was terrific as well in terms of his leadership, and it led really to ARPA-H, his initiative that he unveiled shortly after he became president, which again provides billions of dollars to really invest in new ways to solve some of these big diseases. And it's be incredible when the chapter is written in terms of what they're able to do. But the bottom line, a real focus on prevention that not a lot of other countries are able to produce, and so they rely on us to get it done. As part of that, we also looked at technology. Susan and I were in Tanzania a few years ago, and it was amazing. In the very rural parts of the land, they were using solar technology to fuel their to provide the energy for their cell phones, of which people could then link up into so many different parts of the infrastructure, even on healthcare. We were in Greece, and we saw they were actually more advanced than we were in terms of COVID, in terms of allowing their population to know when they needed to get their vaccine, how alarming was it? They were able to trace people. I mean, a whole number of different things. Where are we, as you look at the rest of the world, where are we in terms of technology so that when the next pandemic hits, we are in fact going to be better prepared than we were 8 years ago?
I think it is a great question. It's not 100% my area of expertise, so I can give you a general sort of sense of, in comparison to the other world. But I think it's not so much about the technology, because we have the technological capability. It's more about the political will and the individual will to deploy that technology. There was technology that's tried to be deployed during COVID, for example, where you could actually have on your phone the ability to communicate exposure, so that if you opted in, people, if you had been exposed, you'd get a phone alert so that you could actually protect yourself or know that you were at risk or you should test, right? But there was not a huge uptake on that from an individual standpoint. I think we live in a society that we really honor the individual will, and I think that sometimes makes it difficult to implement certain public health pieces. We are a little bit archaic also in our technology in terms of our communication between our public health system and our medical delivery system. This was a major issue in COVID. In fact, the divide, the cleavages between our public health system and our medical delivery system are quite severe and put us at risk for another COVID pandemic. Some of it is built up in the fact that our public health systems tend to be state-funded, very locally funded, tax-based, and fractured. And the medical system is driven much more by the private sector and sort of has some more holistic and Medicare and Medicaid options are more federalized. But, to give an example, when there were outbreaks in communities, the way that we have funded our system and the way that the information was transferred in this country, and colleagues and I wrote a paper on this in Health Affairs that came out last March. What happened was that we would see outbreaks in communities, but the hospitals weren't getting that communication, if you will, so they couldn't move their facilities into communities or try to address the outbreak at the heart or to kind of find ways to prevent people from getting sick in the first place. It was very reactionary. And equally, when data came in, we discovered that Chelsea, which is a community just north of the city, was one of the highest incidences of COVID in the world by March of 2020. We discovered that not because the data was coming out of Chelsea and communicating to the hospitals or the hospitals, but because a resident in internal medicine was walking the ICU and realized every last name seemed to be Hispanic, and then looked to see, or of Latin origin, and looked to see where the zip codes were of the patients, and basically found all the zip codes were from Chelsea. That's how we figured out that we had this extraordinary incidence coming in our own community. And that allowed, on a very delayed level, services to go into the community that focused on trying to stop prevention. Other countries were far more ahead of that, far more effective. South Korea very quickly mobilized data into the communities to be able to track COVID and to report in a way that when those communities were able to be identified as having COVID, very quickly communication went out. There was support put into the communities, and they had much lower sort of per capita instances of COVID.
So organizations like WHO, have they looked at that and try to be better prepared as we look to the future?
Have we in the United States?
Yeah.
I can't speak to
Well,
that.
the WHO, I mean,
The WHO is certainly pushing to increase the amount of data availability and sharing that happens. There's long histories of trying to increase that and to build that reporting, but the WHO is a little bit beholden to its member states. So the WHO is not currently funded to set up those data systems in every country. So Malawi has to set up its own data system and be funded to do that, and then it has to get linked to more global systems. We also have to be willing to share information, which gets tricky in the land of security, and that's where the international health regulations and the pandemic treaty have been trying to kind of negotiate, but when you get into the autonomy of countries, it breaks down a little bit. The technology is there. I don't think it's fully deployed in the way that it needs to be in this country, but I think more importantly, it's a question of how we're linking, sort of where we're linking the information to, and then how we're using that information to respond and where we're responding, if that makes sense. I'm
really
happy to
talking
follow up with more information or to think about that a little further than I can offer today.
You're really talking about our experiences that most of the resources were in the private sector or the nonprofit sector in the hospitals, and it was not properly linked with the public health system.
Exactly, if that was one of the chief problems, but also we had not scaled we had reduced our surge capacity and our testing capacity so that we only had enough tests in this country actually and we opted to offer them into the hospitals, for example, to protect our health workforce and patients. The result was there were not a lot of tests available in the community, so you couldn't shut down transmission where it started. We were getting to we were managing it when people were sick enough to be in the hospital. And so a lot of healthcare costs ended up there, but we weren't necessarily stemming the spread in the community, which is where it spread, right? Yes, there were nosocomial infections in the hospital, but the reality is we were seeing COVID because we weren't managing it. It was spreading like wildfire externally. So I think part of it is more, it's an underfunding of our public health system. It's not putting the data systems and surveillance in the full ways that we need, and then not allowing them to communicate across state lines and having that kind of coherence. The CDC has tried to put some money forth, but I think what also is happening in our political climate right now, it's feast or famine or drought or deluge, right? And so you need sustained, consistent funding in public health to make it work. If we're going to give it and then take it away, there isn't enough time, one, to see the impacts of it, and two, to build out the systems, which unfortunately take time, right? When is the best time to plant a tree 30 years ago? Well, the next best time is today, but we have to sustain it. And I think, unfortunately, our political environment in this country has shown that we don't stay committed to big premises.
Susan.
I want to focus on your first recommendation about investing in the resilient health system. And to me, health systems are the people, the doctors, the nurses, the techs, the staff that run those health systems. And you, in your capacity as leading SEED, have been all about investing and training doctors and nurses and medical professionals. And often, we who are not doctors listen to our doctors and listen to our healthcare professionals and typically trust them more than you trust elected officials. You trust your healthcare provider. What do we need to be doing as a country to focus more on giving them more strength, giving them more voice, they are unsung heroes, and how do we invest in them in a way where they are leading the charge on these health outcomes relative to climate? How do we, what are your ideas about this resilient health workforce, and how do we give them, how do we give them a voice and make them the voice that people we believe will listen to?
Well, thank you for your, as a healthcare worker, thank you. And for somebody who's advocated with them for a long time, I do believe that the healthcare workforce is the leading edge of any strong and resilient health system. And healthcare is fundamentally a human-centered intervention. And I think that, so while technology and AI will augment, we need our healthcare workforce. And I think that in the setting of COVID, I served in ICUs in COVID. We had no medicine, we had no vaccines, we had nothing but each other to solve and to think through how we were going to be able to mount this. And Mass General surged to, I believe, about 14 ICUs. We became an ICU hospital in the setting of COVID. And there was a real sense of community, but it was the innovation of the healthcare worker that kind of championed that. And so we do need to invest more in them, and I think that, and build up their voice and their link. I think one of the most important ways is to actually bring the health workforce better into the community. Now, I'm a physician, and SEED trains doctors, nurses, midwives, but we partner with community health workers. And the U.S. in particular has not championed the idea of community health workers or community engaged medicine fully in the way, but that is where most people are going to have access rather than a hospital, is being able to get their questions answered within the community and they're understood, right? And the problems and the context and the social determinants are better understood in the community. And so I think that there's an opportunity for us to really invest more in the aspects of our primary healthcare workforce, community workforce. To that effect, we could be increasing our investments in things like our National Health Service Corps programs that make smart, that help support smart talent to be available into places of deep need, and to really help to think about what that service looks like. One of the things that is going to be important is freeing time for health workers to be able to communicate with their patients. And the health system has gotten pretty, the autonomy is gone in the way that it used to be, and there's a lot of different levels of kind of administrative and other pieces that can be exhausting and make it very difficult to have the time and space that we need. The demands are also going up. We are working now that the amount, there's waiting lists to see patients that are months long, which shouldn't be the case if you need access to a specialist or something. And so part of it is an access issue. Part of it is creating the time for the health workers to do it. Part of it, though, is education. We need to help educate health workers to also understand why this is important, not just the clinical pieces, but why the engagement in the community is critically important to being able to change the health outcomes of their patients and can really help to turn the tide against some of the challenges that we have. And there are initiatives that are being led right now, especially within the climate and health realm, to be able to shift and change that. I worry about healthcare a lot right now. I worry about who's choosing to go into it. I worry about how we reward it. It's not, health and I think that we are facing shortages now of healthcare workers in this country that we are not actually fully identifying, but that we are going to be feeling in a decade that is going to make us more vulnerable, especially in the setting of what we're seeing in climate change. And we are importing increasingly health workers, which destabilizes the whole world. Because when countries like Sub-Saharan Africa are pouring public sector funding to train their health workers, and then they're going abroad to Australia, the UK, or the US, that is just creating a snowball effect of problems. And then we're bringing folks into this country to fill gaps that we're not training on our own. And when we're about to have a major debate on immigration, I also worry about what that's going to mean for the health workers that we rely on that are immigrants here. Sorry, it's a very broad answer because there's multiple pieces that come into, I think, what is a really important question, but it's not a simple and straightforward one, but it is critically important.
Rachel Levinson.
Thank you very much for just an amazing presentation and your ability to pull statistics out at such a level that really drives home the messages that you were providing that I think this group needs to hear, even though we're a very welcoming audience. And we don't see that everywhere, not just in this country, but certainly globally. Everybody here has seen a number of examples that through COVID of what the problems were with, you mentioned misinformation, disinformation. We can see that, but like any delivery system, it's the last mile that's the most critical and difficult to overcome, getting to the homes. So when you talk just now about healthcare workers and the need to arm them with time, that's most critical, but also information on the way to deliver deliver effectively to the people, their audience, their immediate audience. So COVID gave us the term trusted messenger, the need to have people in the community who are the neighbors, not just the healthcare workers, before they get to, a patient gets to the point where they need to go for care. Peter Marks said, FDA, we were very good at developing vaccines very quickly. We weren't very good at getting vaccinations. And it's the individuals that we need to reach in a way that they feel comfortable, that they listen, that they aren't persuaded by other louder voices nearby, that we should not have trust in the medical profession or the researchers or the federal government or those parties that made it so difficult to get that out, and that was so problematic through COVID. And I'm starting to see the National Institutes of Health giving money for dissemination and communication measures, learning the research underlying that to be able to understand how you can effectively reach the populace. And I think that that's really critical for the resilience that you talked about, so that we're ready in advance and people are willing to listen and believe in the medical and the healthcare and the research community, which right now that has diminished somewhat. So I don't know where, you kind of said that WHO is dependent on the member nations, and that's absolutely true. But what is, given the global nature of the healthcare workforce that you also just described, what do you think WHO could be doing to encourage the dissemination of information and research? It seems to me that's such a large and critical hurdle that we have to overcome. What would your views be?
So I 100% agree, and I think that it's interesting because on the light of Representative Brooks' question as well about how do we have create trusted voices. The reality is, though, is the voices have to be heard too, and we live in a time where there's extraordinary channels of information and people can live in their little mini ecosystem of Facebook or social media or specific news channel that makes it very difficult. So a couple thoughts. I think that in terms of the WHO does, I think, a very good job, and misinformation is part of the WHO's awareness and key campaign. And I think that they do a great job of trying to get information out there. They're trying to be creative about what their communication strategies are and to make that information. But the reality is the people who aren't listening, the people who live in disinformation don't trust the WHO anyway. So having the WHO come out and say things is not helpful. The reason why I say they're relying on member states is where the WHO, to me, has extraordinary value. It's not only just being, I think, a important just general voice about truth and data and really bring forward like key pieces, but when I say they're relying on member states, that they can do really extraordinary job of providing recommendations for member states to follow and member states to kind of enact, and that's a really powerful tool for scale. But with the misinformation piece, I think that we do need to think about communication as a public health and a security issue. And certainly in the context of climate change, which is already polarizing, right? How do we communicate the health effects of extreme weather, the health effects of extreme heat, the health effects of salinization of your water and just changes that are happening, right? So the words matter, and this might be where we also need to support our healthcare workers is how do they communicate? But I will tell you, when someone's really sick, their opinions change. The number of patients that I was about to intubate in the ICU who hadn't been vaccinated and begged for the vaccine in that context was shocking. And so, I think the problem is people they wait to get sick to understand why that truth matters. And the thing that I constantly heard is I didn't understand, I wish somebody communicated. And so the key to communication to me actually is who are the trusted allies, right? Who are the trusted allies that might be able to cross those lines or build that space or build that trust and can, help to communicate in those silos channels. And I think being very intentional on where you can get into those communities or how you can create that level of trust is important. I actually think, again, if we use the right language, you can work with governors of certain states to disseminate the right kind of information to their populations or their communities, even if they're not mass believers. There are ways to maybe find the compromise. But I think communication is critically important, and it is a strategy that within our global health defense we should think about, because misinformation is one of the biggest things that we are up against. And using the language of climate change doesn't help in the climate and health sphere either. So I think it's a critically important point, but I think who the messenger is matters, and I think the words that are used matter. And I think that there is a lot of ability to be very strategic on that. And I think some folks are trying to work in that space to think about how we can create, do a better job of getting the right information and agency to people so they can protect their health.
Thank you.
Well, thank you, Dr. Kerry. You are most impressive, and we appreciate your being with us today, and we appreciate all the work you're doing around the world. So thank you again for joining us.
Thank you.
And now if the members of the second panel will come forward, then Dr. Shalala will introduce you.
I asked Asha to do it. I don't think she wants to do it. I'll do it. Pardon? Can't hear you. Yeah. Yes, we'll talk about it. Yeah. Welcome. This panel is on the impacts of One Health. Government and military officials who are here will examine how climate change alters factors such as how pathogens adapt and the availability of hosts, ecosystems, and land use, adaptive capacity, food security, and human health. And we have a very distinguished panel. Commander Matthew Casper, Branch Chief, Global Emerging Infectious Surveillance, the Armed Forces Health Surveillance Division, the Defense Health Agency in the Department of Defense. You have a lot of long titles.
It's long, yeah.
Julie, you're going to have to tell me how to pronounce your last name.
Tartan.
Ah, okay, Trichao. Director of the Climate and Health Program Office, One Health Lead, Executive Director of the National Integrated Heat Health Information System, the National Oceanography and Atmosphere Administration, and Gwen Coleman. Dr. Gwen Coleman is Director of the Office of Scientific Coordination, Planning, and Evaluation at the National Institute of Environmental Health Sciences and the Strategic Advisor to the NIH Climate Change and Health Initiative and at the National Institutes of Health. And I should say that Dr. Coleman has really, over her career, actually defined the National Institute of Environmental Health Sciences with her work. It's very nice to see you again. Commander?
Thank you. Members of the Commission on Biodefense, thank you for the invitation to speak with you today on this important topic. As mentioned, I'm the Chief of the Global Emerging Infection Surveillance Branch, which in its acronym form is known as GICE, and I'll refer to it as that. We're a program management office within the Department of Defense that provides funding for infectious disease surveillance to DoD laboratories around the world. And this is in collaboration with their host nation partners. Partners include laboratories such as the Walter Reed Army Institute of Research, Naval Medical Research Command, and those associated laboratories that they have around the globe. In addition to well-known laboratories and institutions such as USAMRIID, Naval Health Research Center, and the Uniformed Services University. Our surveillance focus areas include respiratory infections, febrile and vector-borne infections, antimicrobial resistance, and wastewater, which focuses on key pathogens like SARS-CoV-2 and influenza, and also serves to identify other known and or unknown pathogens that might be circulating in communities. To ensure our approach to surveillance is comprehensive, we have several cross-cutting initiatives that are spanning each of those focus areas, including leveraging a One Health framework to help look at where there could be zoonotic infections occurring, and next-generation sequencing technology to assess how pathogens spread and change or evolve. While we don't have any specific focus area dedicated to climate change, we are acutely aware that the distribution and spread of pathogens and pathogen vectors are impacted by changes in climate. To identify changes, routine surveillance over time is critical and must be sustained for the importance of understanding when you have anomalies or significant differences from an established baseline. At the same time, we seek to ensure that the data generated from our surveillance activities is feeding into greater efforts. Influenza data that's collected across our network is being presented on the annual basis to the FDA to contribute to next season's influenza vaccine composition. And that's coordinated through our partners in the Defense Center of Public Health at Dayton, Ohio. And routine monitoring of antimicrobial resistance is occurring at military treatment facilities that will enable intervention to prevent nosocomial infections, and that's done by the Walter Reed Army Institute of Research at a greater level of characterization through whole genome sequencing. In addition to the vector surveillance throughout our partner network to inform of infectious disease threats around the world. An example of detecting an anomaly, pandemic H1N1 detection in 2009 first occurred at the Naval Health Research Center. And most recently, GEIS-funded partners have been some of the first to detect emerging SARS-CoV-2 variants as they first appear in a given location. And just in addition to routinely identifying novel pathogens or emerging pathogens in new geographic locations where they're not expected. As part of our surveillance, our program has put great emphasis in recent years on incorporating next-generation sequencing into activities. Greater than 80% of our portfolio includes a sequencing component, and these efforts provide a greater level of characterization and understanding of the pathogens and vectors that are being encountered. While the work is technically complex, populations around the world have become familiar with hearing the results, maybe without even realizing it. Think back over the past few years, how often we would hear of a new variant of SARS-CoV-2 that was drawing attention. It's incredible to think about the depth of work that goes into those findings and how routinely we as scientists or those with non-scientific backgrounds became accustomed to it. The identification of variants come from the characterization of these pathogens via sequencing, and the term variant quickly became ubiquitous in discussions and quickly moved into the nightly news cycle during the COVID-19 pandemic. Monitoring for infectious diseases and their hosts and vectors can be a key indicator of the impacts of climate change. Animal hosts or vectors typically have some sort of ecological parameters with respect to where they're found, and changes to these distributions can demonstrate the impact of changes in climate leading to global health changes, likely as much as the migration of people. Associated with the vectors are the pathogens that we would be concerned about that can lead to infection, a potential consequence of climate change that we need to closely monitor and to ensure that we understand from the first identification what we are dealing with. We may notice the climate changes before the changes in vector distribution, offering the opportunity to anticipate where surveillance can or should be established, but it may take the impact of the infectious disease event to capture our attention. For example, and I think as was made reference to earlier, recent reports indicate the conditions that can become, in the US, for example, becoming more favorable for malaria transmission. Warmer winters giving mosquitoes the opportunity to start reproducing earlier, and meaning that their populations can grow to a point where they may have a higher probability of biting an infected person who has been to a malaria endemic area. And surveillance efforts can hopefully lead to the mitigation needed to ensure that we can avoid a nightly cycle of pathogen updates. It's important to understand how much of our biological and infectious disease surveillance is increasingly reliant in the areas of computer science and information technology. The need for adequate server space and computational power to conduct the analysis needed, and having the bandwidth to share files for collaborative projects. And most important, ensuring there is expertise in not only what you would expect in terms of infectious diseases, but also computer science as well, just to conduct the analysis required to understand how pathogens may be changing. And overall, it requires cross-cutting expertise, from computer scientists to biologists looking through a microscope to epidemiologists or physicians working with local communities anywhere in the world. Finally, I don't think there is a singular direct connection between climate and biodefense without intermediaries, such as health surveillance, biosurveillance, et cetera. And these are areas of focus that need to be included in the conversation. And ultimately, it's not a singular effort of any one department, agency, or institution. In my role as chief of GEIS over the past 2 years, I put significant emphasis on engaging the interagency and non-government organizations to ensure that we have a strong understanding of the global infectious disease landscape for emerging pathogens. Last year, we instituted a program-wide summit that enabled our DoD partners and also colleagues from the interagency, such as the CDC and NIH, to come together for a multi-day focus on how we're utilizing next-generation sequencing to characterize pathogens and use for pathogen surveillance. And just several months ago, held our second summit, building upon those discussions to focus on vector surveillance and the pathogens they may harbor. These efforts include discussion and coordination with our interagency partners on issues also such as common data standards to efficiently share and compare data across the government. In conclusion, our way forward must continue to focus on advancing technology and working together throughout the government, academia, and non-government organizations to address the continued threat posed by pathogens and changing climate conditions that may favor them. Thank you for the opportunity to join you today, and I look forward to your questions and hearing from my colleagues.
Thank you.
Thank you.
Ms. Trahaja,
Julie. Would that work? Just Julie. People call me Julie. Thank you. Thank you very much for, do I get his extra time? That's what it looks like.
I can yield my time.
Good morning. Thank you so much for the opportunity to be here. My name is Julie Turton, and I'm in the National Oceanic and Atmospheric Administration's Climate Program Office, and I lead the Climate and Health Program there. And interestingly enough, I have to pause for a second because the title of this session, Under the Weather, is actually the title of the very first National Academy report on climate and health called Under the Weather. I've been at NOAA since 1996, working on the climate and health issue ever since on oceans and health and One Health for quite a while. So it's a full circle for me to be here. So I'm very pleased and honored to be here. Thank you. And I'm also glad that you thought to invite NOAA because we have been at the table. And although you're new to GEIS, one of our very first partners was with GEIS on Rift Valley fever, trying to understand the environmental drivers for how the whole system works. And so when NOAA comes to the table in this equation, when you think about the context of One Health being ecosystem health, animal health, and human health, we're the environmental people. We bring the prediction science, we do the earth observations, we do the forecasting of heat risk, of air quality, of even wildfires and air quality that are linked. So we're the environmental piece of the One Health equation. And that's often not at the table. So my job is to make sure we're at the table. And I'm really grateful that we're at the table physically right here now because you'll hear later, and Dr. Koresh has been singing the song for quite some time too, but very often it's either animal health or human health and the environmental piece is not around. And so NOAA does have a One Health initiative. We have capacities, not just for the environmental information, but how we engage, the partnerships we build. And I will say just one other piece on the animal side, we are responsible for the marine animals and the fisheries. So we also have an animal health component to it that is often overlooked on the aquatic and marine side. So that's why we are even in this space. And in our One Health program, we actually have the traditional health focus with vector-borne and waterborne and air quality. We have international and regional. We don't have an explicit national security focus, but we do often work at that interface because when you, as Dr. Kerry said so eloquently before, when you actually look at the interface, it's hard to separate out, physical and biological threats from threats to security, from migration, from pandemics, from things. And so one of the things that keeps me up at night is that we are still surprised by these things. We understand a lot about these environmental factors, but we are not integrating that well into how we manage our systems. We're still in a surveillance and response mode, even though we talk about getting predictive. We are not there in a sustained way. And I'm going off my own script a little bit, but I want to build on the cholera example. We actually have over 20 years of research. We've started some of the research with multiple other agencies, understanding the environmental drivers for cholera in some situations. And we can now predict cholera with relative certainty and with about a month lead time. That would give medical professionals a really strong chance to get ahead of that curve. Or for Rift Valley fever, you got to go in and do the vaccinations before the roads wash out because the rains are coming. We can help get ourselves, our countries, and our people, our populations better prepared, and that actually provides much more stability. You don't have the migration issues, or you don't have as many anyway. It's not going to solve all the problems, but we are still operating in a bit of an antiquated context, and we have the capacity. We need some funding, we need some political will, but we have the capacity to do much better, to shift our paradigm from how we work, to be not responsive and not surprised, but better prepared and predictive and preventive. So that is one of our big goals at NOAA, is to really help shift the paradigm. We do a lot of forecasting, as I mentioned before. We do forecasting not just for the weather and heat. One of the titles I have is I actually am honored to lead the National Integrated Heat Health Information System. And that is now a 30-agency activity to address heat across timescales. And we have managed to brief Congress on that and not ever use the word climate change, even though I am in the climate program office, and it is very driven by changes in the climate system. So to the discussion earlier, you can have the conversation about a lot of these things depending on your audience. The bottom line is, how does it affect people and how does it affect their livelihoods? And I would also concur that we need to educate folks, but we also do need to quantify the impacts a little bit more. We don't really even have very good numbers yet on what are the heat impacts on economics and populations and productivity, companies and small businesses. We do have a little bit better data on some of the health impacts, but even that is weak. And as you all well know, the health data systems and the availability of that data to come into a prediction tool or to be shared is continually a challenge. But we can do forecasts. We can use the forecasts we have. We can certainly improve them to make them more relevant for our health partners, because right now they're at a scale that sometimes isn't always most useful. And then, so I think in terms of using the environmental information and also remembering that we have a marine component here, we're looking at things that get to not just human health, but food systems and food security and food stabilization. So yes, that actually does get back to human health. But if you look at the different systems, we've got a whole network of food system, food supply, food security that are driven by weather, changes in weather and climate patterns. And that definitely gets back to the human health impact. But I think we need to quantify that a little bit more and articulate the whole food chain and food supply system. And some of the civil unrest is in part because you have an extended drought. You don't have enough water, you don't have enough food, so you get migration across borders, you get across states in the United States. So I think we're not giving enough attention just yet to the disruption that the food supply and the supply chain is causing our societies, not just in the U.S., but globally. And so a couple of the things that I think are really important to do is, one I mentioned already, is that we really have to shift the paradigm of how we work. And while it's incredibly important that the health sector is recognizing that climate is a big issue and that One Health is really important, the way we work still has to shift and make sure that we are shifting to a prevention and prediction mode and really getting ahead of the curve, that we are honestly engaging the environmental and climate side. I've seen even recently, I've been involved with WHO and WMO in a whole effort to build climate services for health. And there was a climate services for health meeting with not one Met service there, not one meteorological service, not one. I mean, it's great to have the enthusiasm, but we really have to make sure that the communities are very closely aligned. And we have to work together differently than we're used to working. It's a paradigm shift on how we talk about it and how we work together, and making sure that we are really all at the table at the same time. So it's not necessarily a sequential thing. The second piece that I wanted to say is a lot of what we do in the heat world is inherently about environmental justice. A lot of what we're talking about is environmental justice. But those words don't have to be used. We can talk about that in many ways, and so we are, obviously quite adept in the federal government of making sure that we use the right language. And the honest answer, though, here is that if the second recommendation would be to really address the needs of the most vulnerable populations at home and abroad, because those are the ones that really are destabilizing for our own health and well-being and our national security. Even in cities in the U.S., there is some science that talks about the need for the relationship between extreme heat and civil unrest, per se. And then the last one is building the institutional and scientific capacity and educating our population. We worked with some of the healthcare workers in small communities called promotores, that they carry that message. We have an example from the drought. Our sister organization for drought is highly supported by the Western Governors Association. So I think we have an education at many levels, down to the healthcare workers and the trusted sources, to some of the things that I imagine you all might be eager to do in working with governors and mayors and getting the message that there is something we can do about it. We have to be supported properly. We need to build the workforce, and we also need a wide variety of advocates moving forward. And I'm over my time, so thank you for your extra few seconds. Thank you very much.
Thank you. Dr. Coleman.
Well, good morning, everyone, and thank you for inviting me to this esteemed panel, and I'm happy to be here with my federal agency partners. I am an environmental epidemiologist by training. I have had a full and prosperous career at the National Institute of Environmental Health Sciences, which is one of the 27 institutes at the NIH. And I have spent my time doing research on the environmental causes of disease, and also as director, program officer and director of the extramural research program at NIH, working to build research programs for academic investigators across the US and around the world to also engage in this kind of research. So in the last number of years, I've noticed the shift, right? So the issues of climate and health historically have been environmental, and then the silo of environment. And so researchers that we were privy to know and support in many ways were interested in this topic, and NIEHS was the place to go for understanding what the priorities are and the research funding for that. And so we had a small program with a few other NIH partners over 15 years ago, and over time, we didn't get traction from the other parts of the NIH to understand the severity of this problem. As it evolves and there's more information in the public domain, and the scientific community understands that this is not a single niche issue, we have been able to build a very strong partnership across the NIH. 12 institute directors form an executive committee for the NIH-wide Climate Change and Health Initiative, and we have been very privileged to receive funding in the last couple of years to use, as we see it, as a catalyst to figure out how we could incentivize academic research to fill gaps that are out there. And one of the gaps at the beginning of this was, the talk about the impacts of climate on the mortality of the population, but not understanding a lot about the individual specific disease outcomes. And so having the power of 12 IC directors, the leadership of the NIH, in general, all of the directors are supportive of our work here. We've worked to not only build a cohesive program built on strong collaboration, we've also seen a lot of energy at each institution with their own community of scientists and clinicians and community stakeholders get interested in this topic, talk about it, incorporate it, and then at the end of the day, put their own skin in the game, as we say, funding from the institute budgets for research that's coming in the pipeline there. So overall, I think we're evolving towards a better ecosystem of funding and consideration of the broad base of questions that are so pressing and that we don't have answers for. When I was asked to come as a representative of the NIH, it was a little bit paralyzing. I'm not an infectious disease person. I can tap dance at its high level, but I didn't know what kinds of questions, deep down. So I did go to my colleagues at NIAID, and we'll say that the new director of NIAID, Jeannie Marazzo, is extremely supportive. She's one of the active members of our executive committee, and in working with my colleagues there and staff there, I was able to get a better appreciation of these issues of infectious disease, One Health. NIEHS has been in the One Health space in the past, but it hasn't been a primary area that I have personally worked in. So I want to bring sort of that to this to say that what I want to share with you today is sort of our agency approach to generating research, funding research, and captivating the young minds and maybe minds of people who are very much disease experts but have never thought about environmental cause of disease or how climate impacts as one of the pressing environmental factors. Dr. Kerry this morning talked about direct and indirect effects, so you have the direct effects of the climate aspects, the heat, the precipitation, the stress that comes along with living through multiple disasters. And so you have all of these disease outcomes that can be considered direct effects. And then you have these indirect effects. So the climate factors work through the liberation of chemical hazards in the soil, air, and water after a disaster. So if you think about Hurricane Harvey, almost a decade ago now, in the area that was hit, there was, a lot of petroleum processing, there was a lot of hazardous waste sites in the region. And so those are communities that have always lived with the burden of environmental exposures, but there was a threat multiplier when these storms came through and the flooding and the air quality changed and all of that. And then it's not the first time they've had a storm, won't be the last time, so they live in an environment of always having this stress. And IEHS, as part of our work over the years, also has had a disaster response research program. So what do we learn from each of these environmental disasters that occur? And if we think about climate, both from the direct and the indirect approaches, populations experience a lot, and we don't have a systematic way to capture what happens. The pre-situation, what are the levels of chemicals in people's bodies before a storm hits, and then what happens after. We have funded work again, in the Texas area, looking at how the microbiome changed in the early days of the storm and later. If you can leverage and use investments in other research that you funded for other reasons, you can then go back and add questions and data collection at the time of a disaster occurring, a weather-related disaster, or integrating climate data into the long-term processing, and it expands the ability to ask many, many more questions from investments that the NIH has made all over this country and all over the world. So, I thought I won't spend a lot of time going through the transmission patterns and all of the infectious disease. My colleagues here have done a good job of that, and we heard about this. And I think this commission knows quite a lot more about infectious disease spread and transmission than I personally do. So I don't want to dwell there. But I want to say that we are following this, and we're trying to incorporate climate and its impacts in the lens of all of this research. And we're bringing together a community of practice of researchers across the U.S., not just funded by NIH, but funded by any of the federal agencies or non-federal donors, like the Wellcome Trust or other philanthropy groups who are quite interested in this space too. And we understand that they come to the question from many different perspectives and lenses, and the work that they've done to this date can help to inform others in tackling these really complicated questions. So one of the premises of our strategic plan at the Climate Change and Health Initiative in NIH is that we want to create new knowledge, new scientific knowledge about the discovery of new climate-related impacts, things that we didn't know before, or for the things that we know, many, many more downstream questions about the incidence of disease, the treatment of the disease, the prevention of the diseases, all that are in this bucket of topics that we've been talking about today. So there's that discovery piece. And the institutes are very much engaged in that kind of research, and the initiative also has the opportunity for people to come in. So things like, what do we know, or what do we need to know about kidney disease after intense prolonged heat exposures, anxiety and depression, mental health outcomes, again, after living with the stress of repeated impacts from weather impacts, and also just the overall worry about a changing planet and what our future might look like. Certainly important in our younger generation. There's quite a lot of eco-anxiety around these questions. The respiratory and cardiovascular health impacts from wildfire smoke, cancers and other chronic disease outcomes from the liberation of these hazardous chemicals after events that I've described. And we're also, in addition, interested in creating an evidence base that goes around what the interventions or the solutions are, right? We talk a lot about the knowledge that we have about enacting solutions. And I would tell you that it's really hard to put together. When you look at the scientific literature in some of the more traditional places, not a lot of publications that are high impact or high visibility to policymakers. I don't think most of them go into PubMed and are looking for scientific discovery data there. And when we've spoken to people who are on the decision-making side or policymaking in countries around the world and in the U.S., they're asking for help to integrate the findings that our scientists are putting out there. So often we say there's not enough research, but there is a lot of research, but it's just all over the place and in its own silos. And there can be a role for integrating this around important topics like biosecurity, biodefense, solution-driven work at the local level for heat, for any of the climate-related, drivers. Or even just compiling this from a position of understanding more about the etiology, treatment, and consequences of having a particular health outcome, right? When we talk about training health professionals, they come from a lens of the disease outcome that they're going to see and talking to their patient about. So how do we build curricula so that medical students can see the integration of the impacts of many, many environmental factors, but also climate, in their curriculum and in their practice? And so how do they start their job as a doctor by going into a patient and not only asking about their medical history, but also asking about their occupational history or their environmental history or where did they live? Just knowing where people live across their lifestyle and geocoding that information really opens up an enormous amount of resources and capacity for us to study many, many things. But those simple things, just think about your own experiences going to the doctor. How often do they stop and ask you those kinds of questions? It's really critical to the future development and impacts around this climate work. Working with communities, also very key, and NIEHS and NIH has a big history in community engagement, but we could do more, and I think it's aligned with the kinds of things that you talked about with communication, dissemination, and implementation. So I'll leave it at that. My time is up, and thank you for listening.
Thank you very much. Julie, you spoke briefly. You co-chair the Global Heat Health Information Network Management Committee. What is that?
So, thank you for the question, actually. So, in 2015, several countries we hosted a meeting to address heat here in the U.S. in Chicago. And it was NOAA and CDC because we realized there was a lot going on in heat. And as Gwen said, research was happening, things were happening, it was very disparate. And we also saw the trends that this was going to be an ongoing problem. And out of that came the use of this integrated information system model to build the National Integrated Heat Health Information System. But at that meeting, we had participants from WMO, from Pakistan, from India, from Australia, from Canada, I think Sierra Leone, a few other countries, and they were also really interested in, like, how are we going to move further, faster together? We can't wait 4 years, we can't wait 15 years. This is something that is upon us now. And so we basically launched the Global Heat Health Information Network. It started as basically we called ourselves a ragtag band of volunteers. I mean, these are people around the world that just knew we needed to coordinate and learn from each other on heat. We had a formal launch in 2018, and that is now almost 1,500, 2,000 member group. It is housed tangentially under WMO, under the joint office with WMO and WHO, and I'm honored to lead their management committee. We've got a bit more of a formal structure. This is the global place where the conversations about heat governance, heat policy, and the solutions and what's working and what isn't happen.
Thank you. Dr. Hamburg?
Thank you. First, let me welcome Governor Ridge, or Secretary Ridge. I never know which title to use, but he is the co-chair of the Bipartisan Commission on Biodefense, and you might have noticed him appear on the screen. He can't be with us, but I just wanted to recognize him, thank him for being here, and perhaps not right this moment since we're in the middle of questions for this panel, but we could hear some remarks from you after this panel as we transition to the next, if that would be okay. But welcome.
I apologize for interrupting at this late date, so thank you.
Oh, and we may need to work on our audio visual because your voice was echoing. So we'll work on that while we continue with this panel, and then we'd love to hear some thoughts from you. Well, thank you, and actually, in my tenure as a federal official, I've actually had the pleasure of working with each of your agencies for different reasons, but over decades now, and have seen firsthand the impressive work that you do. My first question was actually going to be to Commander Casper on the GEIS program, which many decades ago, I was health commissioner in New York City and began really working on the issues of emerging infectious disease threats. And then joined Donna in the Clinton administration, and we began to work on a whole system of bio-preparedness and public health, including bioterrorism and bioweapons threats. But I went from, thinking in a very narrow silo about public health and infectious disease to much broader, and I was frankly quite amazed when I learned about GEIS. I thought, wow, there's this whole network that enables earlier detection, sharing of information, a global footprint, and engagement with other countries that we needed to partner with. I'm curious whether, as in the course of its existence, has it been able to be resourced adequately to do its job and adapt to a changing world? One of the issues that became contentious at one point had to do with work in country labs that wasn't absolutely clearly benefiting the countries in which those labs were housed. And I don't remember all the details, but I think it had to do with strains of a pathogen for vaccine development. But I'm wondering, as you look, sort of over the course of time and where we are now, if there are recommendations that you have for us about how to ensure that this important asset can be sustained, are there ways that we could actually make it, sort of more valuable to the countries in which you work, the people that it serves, and demonstrate that value to the U.S. people who I think don't, it isn't always clear why investments in these kinds of global activities are in their own, interest.
Yeah, thank you for the question. I think to start out, GEIS was established in 1997 through a presidential decision directive, the NSTC 7 on emerging infectious diseases. And that sort of initiated GEIS. And then, since that time in the 25 plus years, the resourcing of GEIS has really come through that national level, or really just that minimum, DoD level initiatives. With the initiation, there was resources, but then you go back approximately 20 years ago and look at the, pandemic influenza implementation plans, putting resources in GEIS was DoD's response to that. You go back 10 years ago to antibiotic resistance and CARB, combating antibiotic resistance bacteria. That was another plus up in resources to our program that we've been able to continue. And most recently in the Biodefense Posture Review, which has allowed us to expand the sequencing work that we've already done. So maintaining the momentum of those initiatives, even though they're dated, is important. And we've seen it with things like influenza. We've certainly seen it with things like CARB, and hopefully with the Biodefense Posture Review that those initiatives would be maintained. And then hopefully we maintain the resources behind that and can continue to do the great work that the labs that we support do. I'll comment on on the overseas side of things. It's multifaceted. I think you can certainly run into the scenarios when working overseas of running into misinformation. And certainly those can sometimes be extremely sensitive in terms of your, I'm working in a US DoD lab overseas, and I'm a foreign entity in that country, and I need to be sensitive to that, and our partners need to be sensitive to that, and we are. And we need to ensure that we're working very closely and collaboratively. Sometimes it's a challenge. I was stationed in Indonesia from 2007 to 2010, which is some reference to what you were making. And the communications failed there, and it was unfortunate. And then we had to close our laboratory and the great work that was being done there. Again, I think it's just maintaining focus on these high level initiatives and the resources that are required to do it.
Can I ask Julie just a quick question? I actually, NIH is probably where my heart really lies, but I'm going to ask Julie. Is there a global forum for some of the work that you're doing that enables the kind of collaboration that you have to have, since oceans clearly are a resource that doesn't follow national boundaries?
Actually, no, there's not a global climate and health forum. The WMO and WHO have a joint office on climate and health. And so there are convenings, we worked on with WHO, this Climate Services for Health implementation plan. How does that work? But there isn't actually a global forum that regularly meets on climate and health in general. The Global Heat Health Information Network convenes every couple of years on heat, but not all of the suite of climate and health issues. And I actually think that would be very helpful. Even, we've wrestled with whether we needed a global research agenda. NIH has been leading, obviously, on that front. And with the investment now and the real interest in the private sector and NGOs and philanthropies, I think that could be very useful, and to at least consolidate what countries have done and what has been done, because there's a lot of money being talked about and being potentially directed, and there isn't a global forum, and there isn't really a common global agreed upon research agenda either. But thank you for the question. It's an important one.
Representative Greenwood?
Thank you. Brilliant minds think alike. You took most of my questions, but for Dr. Casper, when you talked about sequencing the virus variants, and you talked about offices that GEIS has around the world, I didn't quite get to what extent other countries have their own sequencing operations going on, so that we can more quickly know what variants are being seen where on the planet.
Yeah, sequencing is becoming more ubiquitous around the world, and especially with the partner nations. And so, many of the laboratories where we support those other countries, be it in Thailand or Malaysia or Kenya or Peru, have those capabilities in country as well. And our DoD laboratory partners are working closely with their respective ministries of health, ministries of defense to corroborate that information and I'm going to say display. That's not the word I want to use, but to display that information, in public forums and on things like PubMed and GenBank, and have that information transparent and publicly accessible.
Okay, thank you. There's been a lot of discussion about mosquitoes, and this may be outside of your experience, but a few years ago, I was actually in Brazil releasing genetically modified Aedes aegypti, I think it was, mosquito males to, the idea was they would go out and mate with the females and render them sterile. I think the company was called Octec or something like that was doing that. Do you know anything about the success of that approach and whether it's ongoing or not, or I haven't heard much about it lately?
No, I don't know, but I would just put a plug in again for routine surveillance as what would be needed to make such an assessment. But that's a bit outside my wheelhouse.
Okay, and Dr. Hamburg asked my question that I was going to ask Julie, and so, Dr. Coleman, just a quick question for you. So with regard to the NIH research, to what extent is the NIH responding to proposals coming in this field versus sending out requests for proposals? That's the question.
Yeah, thank you for that question. We do it both ways. We have open solicitation. We have a statement out on the web that shows the breadth of our interests. We have a strategic framework document on our website that the scientific community can look at and see how their work might, be of interest to any individual institute at NIH or to the overall program. And we have put out a number of solicitations specifically focusing on developing capacity for transdisciplinary teams. So different kinds of researchers, climate scientists, health scientists, social scientists, across the gamut to work together with community members at a local or regional level in order to start building those trusting collaborations, identify the research questions of interest at the local area, and then, go on a path for a solution-driven research. So the response to those things are overwhelming. We just funded 21 of those in the last year and a half, and the number of applications was many, many, many more. So unfortunately, good science was left on the table right now, and then we hope to work with this cohort of these centers to develop, understand the gaps, understand the community needs. And we have another program that's focused specifically on academic and community partnership building, and we have 4 of those. Again, we got a lot more than 4 at the time we solicited for that, so we could, we would love to be able to support more of that, both in important areas that are impacted by climate in the U.S. or also around the world.
Thank you.
Thank you. Representative Upton?
Well, thank you all for your comments and your preparedness today, and just in an effort to further revise and extend my remarks, complimenting the wonderful work of Peggy Dr. Francis Collins was also a very key player in terms of getting our 21st century cures done, and the 2 of them were real leaders in helping us vote for the bill that really did have a major impact on not only the U.S. But the entire world. And I guess a little bit, I was pleased, Dr. Coleman, that you were here, and there's a little bit of an elephant in the room, as you might imagine, with the election about a month ago, and I know that Dr. Collins was a strong supporter of the function of your division. And I just wonder if you want to comment on any chatter. I mean, there's been some remarks, anti-climate already that have taken place by some of the folks in the transition team, and and we're going to have a new director of the NIH, so we'll see how those hearings go. But can you comment at all about the attitude of the folks in your department at all as you look to the future?
So thanks for giving me that little softball question here.
Yeah.
Appreciate that.
Yeah.
Let me say that the strategic framework for our program is broad and expansive, and the work is critical. And we have made investments. And so, the staff that are engaged, there's 200 interested program officers and scientists at the NIH that meet monthly around this topic. We have a strong steering committee of people who are, actively doing the work, managing all of these programs. I mean, we're committed to the science that we have supported, and we continue to, look for opportunities to continue the work. And I think I'll leave it at that.
That's good.
Yeah.
Representative Brooks?
Wait, I had one further quick question. Is that all right? Donna, can I ask one other quick question?
Ask another question.
Oh, who does? Fred, you want to ask another question?
Yeah, just a quick question. So one of the things that drives home the message of climate change to our constituents across the country is hurricanes and fires, all right? So is there anything specific that you can tell us as it relates to your work at the NIH relating to those 2 that you've developed?
Sure.
The advent of we had more hurricanes that are more devastating than ever before. The fires, whether they be in California, Alaska, or Canada, even the Upper Peninsula of Michigan, impacting the air quality of hundreds of millions of people.
Yes, I couldn't agree with you more. These are very important environmental episodes that occur and impact people across their lifespan and across, different vulnerable groups. I could tell you in the wildfire space, we have supported quite a lot of research there, trying to understand the respiratory, cardiovascular impacts of short-term exposures to smoke. Also the longer-term exposure consequences for these populations. We've supported work in California and in other parts of the world where population studies have the opportunity to, continue to assess the health impacts of communities that have these. We've also learned a lot about the unique exposure scenarios that come with wildfires. So when a wildfire is out in a purely forested area, it's one kind of smoke. When it ravages through communities or urban areas, it's a totally different kind of smoke that has different constituents. And then these are these indirect impacts of these outcomes, because now people are exposed to this sort of much broader morass of chemical, physical, and even biological threats that come from these kinds of things. We also have a data program that we're working on now, the integration of climate and environmental data with electronic health records and data from epidemiologic studies that the NIH has invested in. And the case study that we're building this around is wildfires. So we want that kind of data in terms of the data sources and the methods and tools to be able to utilize that data appropriately to be more readily available to researchers. And we're building, open access catalogs and working on the kinds of issues of what kind of tools and statistical methodologies are needed to address all of these questions, not just on the biology of the disease, but also on the health services and resources that are needed to, support communities' recovery and, aftermath of these events.
While we're here in New York City, this discussion reminded me of the work that we in Congress did relative to the 9/11 first responders and the environmental impact that many of those first responders have had on their health. And I'm curious what you all would say to the incoming administration, as well as to the American people, as to what do you think right now are the two greatest threats? And I'm ask each of you, and I hope they're not all the same, but the two greatest threats to health relative to the environment that there are right now to Americans. Anyone want to start?
Commander?
I'll start. I think I've got one off the top of my head, but I think relative to the environment, just going back to how changes in climate can lead to changes in vector distribution, and it expands where ticks can get to, where mosquitoes can get to, and that's something that concerns me, just in the context then of these things moving into new areas and people not being familiar with it, and so. Certainly mosquitoes are pretty much ever present and you know when they're around, but ticks not so much. They tend to do a better job of hiding, and if they stick around long enough, you can end up with some sort of infection. So that's one that I have.
Thank you.
Turn it over to my colleagues.
Thanks.
So for me, I think the first one is heat. I think I started out at NOAA doing a lot of infectious disease work, and the work that we funded initially was at ecologically mediated diseases and the like. But since I've been working on heat, I realized that the sort of insidious nature, you can, the direct impacts are pretty obvious. You get hot and the physical piece, but it permeates society in ways that we are not even beginning to really understand and see. It's how we, It's going to affect our work days, our kids, our ability to learn, our mental health, the chronic impact of long-term heat exposure, not just on kidney disease, but other bodily functions I don't think we understand. I think heat is really a pervasive impact on our society that we are just scratching the surface of. That's the big one for me. And the second one is, I'm a little torn because I want to say infectious disease, but I'm not. I'm going to say the mental health issues of all of this. I think for the younger generation, I think we're also not really addressing that. And I say that because some of the reasons that people are more vulnerable to the environmental factors have to do with their own mental health and some of the medications they're on. So I think the mental health aspect needs to be unpacked and worries me a bit for the future generations, not so much us. We're already messed up. We're going to deal with it.
Yeah, I think for me, a priority is to keep the research going, right? There's so many questions in this complicated mess of things. And oftentimes we run to solutions before we have an appropriate evidence base. We wouldn't do that in other parts of medical healthcare or health services, but we environmentally we try to figure out maybe the policy change or the how do we reduce something without actually having a rigorous set of studies that show what works and what doesn't work. So prioritizing research through all of this is important. Learning from our experiences and collecting data from a health lens for whatever changes we make in our environment is critical. And then I guess the next priority is making sure that people have access to all of that information. People in communities that are, have been burdened for decades with environmental burden of diseases, they don't have access to this kind of stuff for them to advocate, for them to protect their families. Local health ministers in parts of the world they're data poor in the local area. So how do you take the science that we have and make sure that it's accessible and available to everybody who needs to use it? And then, encourage the people who generate the data to be the technical assistance folks to help those people understand what this data means and how they can best use it for their own solution-driven needs.
Thank you. Good. Dr. Koresh? Billy?
Well, I have so many questions, but
Time.
in so little time. So I'm just going to start because I want to follow up with the 9/11. So now you've diverted all my questions. Have gone like, oh yeah, this is a good idea. So one of the findings, of course, post 9/11 in the commission was that agencies were not speaking to each other. That was one of the weak points we had. And then, and I'd really like to talk to you about global health. But I'm going to focus back on the U.S. and what we're doing here. So how are you, I think because you've mentioned this interest in bringing other people into the world of health, and NOAA's been doing that, how are you seeing that kind of collaboration across agencies? It's really meaningful, rather than just your occasional meetings where everybody gets, maybe that's important enough, but I'd love to hear your perspective. How are you breaking down the ministry, the agency silos that are built on academic expertise and really helping each other?
Go first.
Go first. I'm probably in charge of way too many of those committees that do that thing. So it's a really good question. Thank you for asking it. And it is hard. I know, as a government, we're supposed to be working together, and we try, but it's often hard. I'm going to highlight the heat one as a really good example. So for heat, we actually now have 30 departments and agencies actually working together. I know we're supposed to be doing that, but any of you who've tried to do that understand that that's actually quite an accomplishment. We chose to do our own strategic plan on ourselves. It wasn't required by Congress or anything, because we wanted to be able to work together and function together. Across administrations, we needed the stability and the ability to work together. So I would say on heat, that is one that falls across every agency mission and mandate. That's why I started with that, because I think that's fundamentally the problem. Each agency has a slightly different piece of that, and no agency can or should own it. I think fundamentally, we have got to shift the way in which our agencies work together. So this look for like one agency to be the lead on heat, one agency on this thing, is just not gonna work to face and manage the problems we have in the future. Heat is a good example of where we have a joint leadership committee. There are 5 co-chairs. I mean, it's a lot to manage, but we're doing it and we're making good progress. I would say in the climate and health space, the U.S. Global Change Research Program, it's the Global Change Research Program. It coordinates on climate and health work. And when NIH was getting into the climate and health space, they had a place to come, and people do coordinate there and organize there. During COVID, we had a really strong working group on understanding the environmental drivers of COVID with DOD and the military there. You guys were doing amazing forecasting that never saw the light of day except internally, which was fine, but they were able to do that working with us in the data. So there are examples of where it's working, but we are working against a system that is set up to keep us siloed. And we are doing the crosscut is probably more successful now than it might be in a few months, because the agency's leadership has to also support you doing that. And that's the real key. We don't have a mandate to work together that sustains across administrations. We do it anyway, and that's where it gets dicey.
Thank you. Thank you. Thank you for your service. 2 outstanding public servants. Thank you very much.
Amen.
Governor Ridge, we'll start out with you after we take a quick break.
Quick break, okay.
I just want to put an amen and an exclamation point around the whole notion that getting agencies to collaborate and work together is like herding cats.
Yeah.
And we had the same challenge putting together the Department of Homeland Security. I really relate to that. By the way, I want to thank you so much for your commitment to the public service. And most importantly, it's very reassuring to me to know that there are some people within the government who are taking climate change as a serious threat writ large globally. When I was in Congress, when this issue came up, there were more skeptics than believers. And so the fact that we've got some people who view it as a multifaceted threat across the board globally, taking it seriously, devoting all this time to this. I do want to say, as a citizen, that right now, sitting in northwestern Pennsylvania, looking out my window at about 4 feet of snow, taking the thought of global warming as a serious challenge to us, not only in this country, but around the world. I want to thank you for your commitment to it. I remember our friend and former chairman, Senator Lieberman, once said, "Today we can see with our own eyes what global warming is doing. In that context, it becomes truly irresponsible, if not immoral, for us not to do anything, to do something. And before we can do something, we have to have professionals within government committed to addressing that long-term challenge associated with global warming." So as a citizen of this country, I just want to extend my sincere appreciation for your commitment to helping the body politic better understand that the threat is real, and that we as citizens of the world, and particularly with the leadership opportunity the United States has in the global community, to take it seriously and to work as hard as we can to address all the problems associated with it. So I thank you for your commitment to public service. I apologize for my delay in joining you, and again, may you and your families enjoy the best of this holiday season. And it's good for me. From my perspective, I've never been a skeptic of it. I didn't do that well in science courses in high school or college, but I know what's going on around me. You look at the hurricanes and the wildfires, and you say to yourself, what in good Lord's name is going on? So I thank you for your work in this effort, and may you continue to do the best you possibly can to herd those cats together so we can speak with one voice, and so that you have the kind of cooperation and collaboration you need inside this administration and future administrations to deal with it as a serious problem that it is. And so I thank you very much for your testimony and for your public service. May you enjoy a blessed and happy holiday season.
Thank you.
Introducing three panelists. Jessica Metcalf, PhD, Professor of Ecology and Evolutionary Biology and Public Affairs at Princeton School of Public and International Affairs, co-director of the program in Global Health and Health Policy. Welcome. Rachel Elizabeth Baker, also a PhD, John and Elizabeth Irving Family Assistant Professor of Climate Health, Assistant Professor of Epidemiology. Yeah, I got it. I knew I was going to stumble. And Environment Society, Department of the same School of Public Health and Institute at Brown for Environmental and Society. And William Koresh, DVM, President of One Health Concepts. We will begin with Dr. Metcalf. Thank you.
Thank you. Emerging pathogens pose one of the greatest threats to health and human livelihood. Vast resources have been deployed to meet this challenge. It's of course worth noting that the scale of these resources is minuscule relative to the cost of a pandemic. However, these resources have been deployed in perhaps three main ways. The first is in characterizing viruses in their reservoir populations. So for example, the $200 million USAID Predict Detect program. The second is in responding to spillovers by surveillance and response efforts. So for example, when viruses like Nipah virus come out of bats and spread in human populations, there's been vast investments to respond to that. And perhaps the third is efforts to increase biosecurity at farms and in laboratories. I'm going to argue at the end of this that there is a fourth gap that hasn't been considered so far. So how does a pathogen become a pathogen of pandemic concern? There are three broad ways this can happen. So first of all, the pathogen might acquire all the mutations it needs within the animal reservoir without ever infecting a human. This seems unlikely, but the sheer scale of animal populations actually means that this is probably one of the important ways this happens. The second is it could acquire those mutations during short trains of transmission in humans. This seems like perhaps the logical path, but it is actually also unlikely, perhaps simply because of the numbers involved. The numbers are small. And the third is via bridge species. So for example, flu coming over through pigs into humans, so from birds into humans. All three of these past pandemics are affected by the changing ecology that is shaping our changing world. And by changing ecology, I mean everything from urbanization to changing patterns of migration to changing climate to intensification of agriculture. For example, Ebola never achieved pandemic potential, but its unexpected spread in 2014 was very much rooted in increases and intensifications of travel networks in West Africa. And similar pathways might be shaping paths to emergence for viruses circulating in animal reservoirs. This is in some sense relatively good news. Changes in ecology are relatively easy to monitor and easy to respond to. By increasing biosecurity on farms through surveillance or through testing, you could be increasing barriers to many different pathogens at the same time. It should also be relatively tractable to understand what's shaping transmission in these settings. There might be low-cost responses that reduce spread of avian influenza in cows that we simply aren't exploring. At a slightly more technical level of biosecurity, investment in vaccines that have the potential to protect agricultural species against spillovers from wild populations also will have spillovers from reductions in antibiotic resistance, even through to climate change and reducing poverty, if we consider this across the global scale. So beyond these ecological features that are important to pathogen emergence, you might be wondering, well, is there a way in which we can narrow in on what is pathogen X? What is the pathogen that we're worried about? There is a pathogen prioritization group at WHO that thought very deeply about this. And their conclusion is that we should be focusing on families or groups of pathogens rather than trying to identify specific individuals. Every pathogen emergence so far has surprised us, and so perhaps we should keep a wider lens open. And we should be focusing on general countermeasures, so multivalent vaccines, multi-purpose antivirals, etc. Another way to think about, rather than trying to narrow in on pathogen X, we can actually ask about all the pandemics that didn't happen. So for example, there are 4 endemic coronaviruses when SARS-CoV-2 came out, so 4 continuously circulating coronaviruses. And yet we'd had 3 spillovers in the last 20 years. If you expanded that back even just 100 years, we should have 15 endemic coronaviruses, right, at that rate of coming in. And yet we don't. If you probe that biology, you identify that immunity might be playing an important role. If you've been infected by one coronavirus, you are protected from others to some degree. So we might have a net of immunity, which could be an important part of keeping different pathogens out. This insight turns the lens to immunity, and this is perhaps what I think of as the missing piece in pandemic preparedness. We've thought about viruses circulating in natural reservoirs, we thought about spillovers, we thought about biosecurity, but the one thing we haven't really invested in or considered is that we each of us have in us this exquisitely delicate sensor capable of detecting all sorts of pathogens and retaining that information. So for example, I could take blood from all of you, which would be strange, and I could identify all the flu strains you had been infected by. So I'd have a window onto your history, but also a sense of what you were protected from in the future. And this immunity is not part of the surveillance for infectious diseases nationally or internationally, and yet a global immunological observatory, something myself and colleagues have called for, would, I think, really transform our understanding of the circulation of both endemic and emergent pathogens. To illustrate this, so when a new pathogen emerges, time is absolutely of the essence. Beyond that narrow window where you might be actually able to avert the pandemic, every month will count towards vaccine preparedness, towards deploying the workforce, towards preparing populations. So we need to know what's happening as quickly as possible. So we need tools to sample individuals rapidly and share that information widely, having identified the etiological agent. I'm sure you all know that there is currently an outbreak in DRC on the border with Angola. Hundreds of people have died. Hundreds of people have shown symptoms of flu-like illness. We have no idea what the cause of this disease is, or at least we didn't yesterday when I checked. So we obviously need to know that as rapidly as possible. But the second question might be, how many people have actually had this infection? We've seen the people with severe disease. There might be thousands or hundreds of thousands of people out there who had it but been asymptomatic. And you couldn't gauge that now because they will have cleared the infection. You couldn't gauge it just by sequencing for the virus or the pathogen, but you could gauge it by looking at their immunity. So you could get a sense of the infection fatality rate. You would have a sense of this really important piece for a pandemic preparedness for planning of response to these processes. So another really important contribution of an immunological observatory. I think folding immunity into new and old forms of surveillance could really transform how we respond to pathogens, both endemic and emergent. So by that I mean immunity alongside sequencing of viruses and other pathogens in wastewater, in screens of blood and of sputum, would give us a transformed sense of gaps of immunity, for example, for vaccine-preventable diseases, but also anomalies indicative of new pathogens emerging, and also a jump on putting in place medical countermeasures, developing monoclonal antibodies, thinking about vaccines. This clearly should be folded into routine surveillance, and clearly dropping these sorts of investments once the pandemic is over is just a bad idea. I'm sure I don't need to belabor that point. All of these pandemic preparedness efforts are, of course, occurring on the background of a shifting climate. Beyond modulating transmission of important diseases, which I think my colleague will speak about, a changing climate can alter everything from human mobility to migration and major healthcare disruptions also by extreme events. We can monitor this using data streams, for example, using mobile phone call data records, and what we find there is that people generally move on a regime dictated by school holidays, but we also see people forced to seek shelter in the wake of cyclones, in the wake of floods. And as they aggregate, clearly risks of infectious diseases, endemic infections might be amplified, but there might also be new pathways, new ecologies created that favor the emergence of infections. As this is happening, healthcare systems are also being disrupted, and this is a real challenge. We've been doing work in the core of malaria areas, and we found that even a week or two of disruption by cyclones can lead to many more children infected with malaria, many more children at risk of morbidity and mortality. Even in the face of increasing intensification of cyclones in some parts of the world and declining progress against malaria, there is a silver lining. We now have a vaccine that we could deploy before cyclone season that could carry children through so that they were protected during this very vulnerable period where access is really limited. So this final point brings us back to the gap in our pandemic preparedness investments so far. In my eyes, immunity immunity to infection is, of course, a huge social good. If you're protected from infection, you're protecting me. Immunity to disease could carry us across these critical gaps driven by things like cyclones. And immunity also is potentially this incredibly powerful surveillance tool that we have yet to exploit in preparing our populations. Thank you.
Thank you. Dr. Baker.
So I wanted to talk broadly about what we know about the impact of climate change on infectious diseases. And so when we think about climate change and infectious disease, like the conversation earlier, we're typically thinking about vector-borne diseases. And this is the link that we know relatively well. We know that climate impacts all parts of the mosquito life cycle, the biting rate, the mortality. The sort of takeaway of this literature is there's often an optimal range in terms of temperature for certain vector-borne diseases. And so if we can think about climate change as expanding temperature around the tropics, so places getting warmer and warmer, that range might shift northwards. So the link there is relatively clear. It's been shown in sort of observational studies, and it's been shown in laboratory settings. However, a recent review suggested that over half of human diseases could be exacerbated by climate change. So think about all the diseases you know that are not vector-borne diseases, that are not mosquito-borne diseases. And there is a cause for concern there that climate change might impact those pathogens. And that's where a lot of my work comes in, is trying to understand better the link between climate and the transmission of sort of non-vector-borne diseases. An example is the directly transmitted diseases. This is a large group that includes all the diseases that are passed directly person to person. Examples include the respiratory pathogens like influenza, COVID-19, RSV, diseases with fomite-based transmission or contacts, or diseases with fecal-oral transmission, such as rotaviruses and the enteroviruses, which is a very large genus of viruses that historically cause polio and currently cause hand, foot, and mouth disease in the US and other countries. So for these diseases, there's some clear signals that climate matters. So most of these diseases have seasonal outbreak in infections. We know the flu season in the US is the winter. Actually, as you get closer to the tropics, you see more year-round transmission of influenza. And it follows kind of an interesting latitudinal gradient as you get closer and closer to the tropics. And when we see those sorts of patterns, it's a good indicator that climate is involved. So these diseases have seasonal outbreaks, and we think that climate plays a key role, if not the most dominant role, in driving those seasonal outbreaks. And also we see latitudinal gradients in the timing and intensity of those infections. As you get close to the tropic, we see more year-round persistence, and in high northern temperate climates, we see annual outbreaks. Sometimes we see even stranger patterns than that. So for RSV in the US, we see biennial outbreaks, where you get a large spike one year and a smaller spike the next year. And we have models that can recreate that that are dependent on climate. So that's sort of the high level what we see in the data. And these are all diseases that are historically under-researched in terms of the impact of climate and the implications of climate change. I'm sure if I asked you how you think climate change is going to impact the spread of seasonal influenza, not many of you may be able to sort of off the top of your head think of an answer. Many of the people in the room would not be able to as well. This is just under-researched. So I think we need more work in this area. It's where my work comes in. The sort of work that takes place in this, we can do laboratory studies. So we can look at how virus viability is impacted by climate conditions. We can do animal model studies. The sort of classic example of that is guinea pigs and influenza. So guinea pigs can transmit a version of the influenza virus, and there was a study that kept guinea pigs in separate cages, varied the background climate conditions, and looked at the rate of transmission between those guinea pigs. Now, the issue is humans are not guinea pigs, and we do not behave exactly like guinea pigs. So that's also where we have to look at the observational data and sort of combine all these pieces of knowledge to understand why climate matters, why we get seasonal outbreaks of influenza in the winter months, and kind of build upon these different threads to come up with some understanding. I think there are two issues with moving this sorts of research forward. One is getting interdisciplinary work done is difficult. We're trying to tie these threads together. There's this lab component that I mentioned, there's the observational data, and then there's been a lot of work sort of looking at sort of instantaneous impacts of climate on health outcomes and infectious disease outcomes, but I think this applies broadly to health in general. But there's been much less work to think about the implications of climate change. I currently sit in a public health school, and I can tell you in public health, actually sort of thinking about future projections is relatively rare. They're doing a good job at sort of robust causal inference studies to look at climate exposures in the present, using present day data. but then we need to work with climate scientists to then think about the future. And my concern is the way that we're training our current students doesn't give them the broad enough education to do that sort of interdisciplinary work. In our program, students take courses in epidemiology. They don't take courses in climate science. So we need that more interdisciplinary education. Some of this comes down to even accreditation for these degree programs. Masters in public health are accredited and they have required course structure. It doesn't leave any flexibility for students to do courses in very different fields. So there's some structural issues there, which means we're not educating the next generation of scientists to do this sort of interdisciplinary work that we do. And then, we talked in the previous session about federal funding, and I know that it's great that the NIH has been sort of launching these new climate and health centers. I still think there is more work to be done, at least where I stand as an academic. Getting federal funding for interdisciplinary research is hard. And often you're going to have to fund teams that don't look like the typical teams. The centers tend to prioritize senior academics that have been in the field for a long time. And honestly, they're not always the people who are doing the sort of groundbreaking interdisciplinary research that we need to be funding. We were asked today to talk about migration, so I didn't want to make some comments about migration and infectious disease. I will say I think this is a research area that is under-researched in terms of the link between climate migration and infectious disease. When we think about climate-driven migration, there's sort of two types. There's a spectrum between this. There's seasonal migration, when people move from agricultural productive regions to urban areas in search of work when the weather becomes less suitable for agricultural growth. And this is something maybe that doesn't happen so much within the US, but very much internationally. And we know that those movement patterns can lead to the transmission of infectious disease. So there's some really nice work looking at how measles in Niger is driven by this seasonal migration pattern. In the US and the UK, historically, we think measles is driven by schooling patterns and mobility and not driven by this climate piece. Then there's the migration we really think about with climate change, which is sort of short-term displacement. People do not want to be displaced. People do not want to move away from their homes. So this is really not something that we're thinking in terms of long-term migration moves. This is people are displaced because they have to flee the location that they're in because of an extreme weather event such as flooding. So I think a classic recent example of this is the 2022 Pakistan floods, where over a third of the population were displaced. Now, following that, we saw outbreaks of infectious disease. This is because people are often moving abruptly into resource-poor settings, in tightly high-contact settings that we know are important for infectious disease risk. And also the things that we saw develop in those settings were the ones you'd expect: cholera, diarrheal disease, fecal oral transmitted diseases, rotavirus. There's also diseases like COVID-19. There was a COVID-19 surge at the time. And that's because you have people, again, in this high-contact setting in these displacement camps, and that is a great condition for disease spread. So bringing it back to the US, where is the risk in the US? So I think at the moment, the great thing about the US is we have great vaccination programs for many of the diseases, like rotavirus, that we might be concerned about. However, that anti-vaccination sentiment is growing, and it's growing at a concerning rate. 2024, we've seen some of the largest measles outbreaks since vaccinations were rolled out. 16 measles outbreaks, over 300 people infected, the vast majority of them children. So this is a real cause for concern, and where I see the link with climate change is that you could have a perfect storm of events where you have people moving rapidly away from areas that are under threat from extreme weather, and then moving into environments which are high contact, which are perfect for disease spread, where people are in close quarters. And then if enough of the population doesn't have the appropriate vaccination coverage, you could get some reemergence of some of these sort of historically eliminated infections in the US. So I think we need to be better prepared for some of those eventualities. A sort of policy link would be thinking about better adaptation plans. How do we respond to these extreme events? And how do we respond to the risk from these extreme events in terms of infectious disease? And this echoes what my colleague said, that we want to understand susceptibility to these infections, especially these vaccine-preventable infections that we're sort of taking out of our minds when we think about risk in the future. But we need to understand where are the pockets, where are the people, where it's often sort of non-linear across the country, it's heterogeneous. So where are groups of people that might be at risk for these sorts of disease outbreaks, and where are they living in locations where we think some of these extreme weather events might be at increased risk of occurring in the future? Thank you.
Thank you. Our friend Bill.
Great, those are hard to follow, but I'll do my best. So I think I'm going to capture some of these same themes and maybe bring in a little more in the environment side. It's so we're talking really about climate and health, and I think now this is my 6th administration where I have to switch to between climate versus severe weather. So today I'll talk about severe weather and health and migration. So we go back and forth. It's fine. Basically, I think we can break down, I think everybody here has a basic understanding of what's going on with these, how weather is changing, climate's changing, and it's really, we could simplify in looking at host and vectors, and then mixed with the environment. So you have changes in the distribution of either the diseases, which links back to the host, like humans or animals, and their vectors. One thing people tend to just say, well, with climate change or warming, the range is expanding, but the ranges are really shifting. So in North America, they might be moving northward. So they're shrinking on the southern side, moving northward. But it's good information because we really want to link this back, because of this meeting, into biodefense and national security, so we can use that kind of information to really kind of target where we need to be looking. So it's kind of that first step. And then we just mentioned changes in seasonality, also somewhat predictable. Yes, there's gaps in knowledge, but there's also a tremendous amount of knowledge. But that's also information that we can use. Even if it's changing, we can put that into forecasting models in looking forward. Basically, it comes down to a change in risk profile. So if we want to engage the security sector and other sectors, we have to, as Dr. Kerry was saying, start to speak the language that others can understand. So we're really talking about risk reduction strategies and changing risk profiles and using this information about climate and health and putting it in those terms of, well, how does that change risk for this population or that population at this time of year or that time of year? So you get a little more comfortable. It's no longer ideological. It's really just about reducing, putting in a risk reduction kind of framework for our agencies to tackle it that way. And then finally, what concerns me a lot is this kind of, with migration, movement of people, whether it's tourist or actual, long-term migration, is the opportunity for spillover. So now we're talking about another outbreak of mpox, or what was called monkeypox. That's come into the U.S. before in the pet animal trade. It came in little rodents and got into prairie dogs in the U.S. and then started infecting people. Luckily, it didn't get into the wild. COVID got into white-tailed deer and has spread across most of the U.S. and became established in white-tailed deer. The plague, originally from Asia, now established in North America and South America, because we have rodents that can help, that carry the fleas. So I think one of the other things we need to be thinking looking forward and in our forecasting models is do we have susceptible hosts? How do we prevent contamination? Does medical waste from clinically ill people get dumped into landfill and exposed to our local animals that are reservoirs and get established? So those are the kind of things we can actually do something about. The biggest migration really are birds. So, Representative Greenfield. So every year about 1 billion or 2 billion birds fly up to the Arctic and have about 1 billion or so children. And it's like a big nursery school of unvaccinated children, but they're birds. And in that time, they're just playing in the water and spreading their viruses, predominantly influenza viruses. That's probably going to be something we can look at with NOAA, look at satellite imaging, changes. Am I out of time already?
No, it didn't start.
The timer didn't start.
Finish.
I have so much time. Anyway, and then those birds migrate down across North America again. Once again, they're predictable, something we can do forecasting for and modeling. Big concern now in the southern hemisphere is influenzas going from mammal to mammal. So we have animal transmission between mammals pretty much being neglected now. Those are strains of influenza. Now they're effectively infect mammals, just like we're seeing in cows, but different ones there. Migratory birds, of course, come back from the southern hemisphere to the northern hemisphere next spring, so we have this opportunity there. So I just want to kind of finish up with saying, one of our challenges that we have to overcome at the government level, federal level, and it's kind of a quote from a colleague, Tracy McNamara. She said, we take an agency-based approach to these challenges and these diseases rather than an agent-based approach. So whether or not it's plague or a bioweapon or influenza, it gets assigned to an agency based on who's the most effective, or USDA, rather than everybody working together across agencies on that. And then I would add that the environment, because of the epidemiological triad, host, pathogen, environment, that needs to be integrated in there too. And it was great with the previous panel about what NOAA and these other groups, environment sector, can contribute. So somehow we have to make some recommendations on how you mainstream or encourage or allow that interaction between the agencies and give them the permission and the mandate that needs to be integrated in. I think the modeling, 3 years ago, I would have never had any hope for this, but what I'm seeing now with generative artificial intelligence, I think these are complex problems that actually now could be addressed. If the NIH environment section of that, all their information was fed into a generative model or learning model, policymakers could say, what's the effect of doing this, or what's the potential effect of doing that? So I think these are, exceeded kind of somewhat human capabilities to be so multidisciplinary, but these artificial intelligence models actually are built to do that. So I'm kind of really, first time, kind of optimistic about how to pull this stuff, how to pull it together. And I'd love to see us engaging federal government agencies to be jumping into that and taking, if not a leadership role, a very big supportive role.
Well,
Thank you.
Thank you all, and I just want to build on that thought for a moment, and that is, and I would have liked to have asked Dr. Coleman in the earlier panel and Noah as well, the great work that we're doing here, are there other countries that are ahead of us? And as I couch that question, it's disappointing to hear that in the answer to the question earlier about is there a global organization, answer is really no. What is WHO doing? And maybe specifically, as we go down the line here, Dr. Metcalf, if you could tell, is WHO in the case that you cited earlier about the DRC, are they involved there? I mean, what's going on? Where is the alerts and the concerns as we did not see in Wuhan?
So perhaps I could start with the first part of the question, which was around what countries have been doing successfully. So I think Britain was actually unusually successful during the pandemic in terms of both the amount of sequencing they did and the amount of actually sampling of at random within the population, right? Because one of the problems is our data is always biased, but all of that was essentially shut down. They're selling off their sequencing machines at auction when the pandemic ended. So there wasn't an eye to sustainability. And I think a sustainable routine surveillance, as someone said in an earlier panel, is really essential, and sustainable routine surveillance that encompasses both virus pathogens and immunity, because I think that really is underexploited, is a key element. What is happening in the DRC right now? I think it's a fast-moving situation. I'm sure the World Health Organization is involved. I'm afraid I can't speak to the details beyond knowing that it's happening, but it is generally the case that there's coordination. I mean, every member state of the World Health Organization is arguably representing the World Health Organization in these settings.
And is there a name for the disease or the ailment, or no?
And who knows, right? This sort of thing happens around the world. I mean, it's always worrying. I've brought this one to your attention. You didn't know about it until right now.
Yeah. Dr. Baker, would you like to respond?
I don't know about specific countries. I mean, I knew the case of the UK during the pandemic had particularly good surveillance work. There are countries that are sort of doing more work and more active thinking about incorporating climate into early warning systems for infectious disease outbreaks. There's tend to be regions, for example, with vector-borne diseases. So can we predict dengue cases a few months out, can we use that information to inform public health? So I believe Brazil has some kind of newer models that are thinking about this, and this isn't something that's necessarily occurring within the US. But there are other regions, and they are regions that get some of these sort of well-known climate-sensitive diseases that are starting to think now about how we can prepare and anticipate those outbreaks and how we can use climate data to develop those predictions.
And Dr. Kresh, do you want the last word?
Well, I would say that, interestingly, I think the U.S. supports some really cutting-edge work, but it's not necessarily done in the U.S. And so Department of Defense, and we heard from them, is doing some amazing things around the world with our allies and partners that may or may not be done here. There was a vector-borne disease forecasting system in South Africa supported by DOD. We don't actually use that in the US, but it was developed. They were interested. They liked the idea, but it's kind of the intellectual capacity. So I think there's a bigger role that the US can play, more public role in taking that leadership work. And even when WHO responds, as you mentioned, very few of those people are WHO doctors. They're doctors from countries like the US and from the UK and Australia that go and respond there, and they do it under an umbrella of WHO. So we're kind of very engaged on that front too.
May I add one tiny piece? So I forgot, of course, for example, the WHO runs fever rash surveillance across the world. And so every country has a center where samples are sent in from children suspected to have measles, and they're tested for fever rash. And this is a resource that could be turned to look at immunity. You know, we have these blood spots from all over these countries. It's a random sample, but it's an existing surveillance network that exists in the settings where these sorts of things are happening.
Great. Dr. Hamburg.
Well, thank you. Thank you for your presentations and the work that you all do. I have so many questions in so little time, so I'll try to limit myself. But first, since you did bring up the cases in the DRC, you know, I get various news feeds in the public health arena, and I have been, you know, reading about it with some interest. I've been struck, number one, that the reports all are different numbers coming the same day, and I don't know if that's just, you know, lags in reporting or inadequate, you know, information collection, but I suppose the latter. But is there, it seems to me that in the modern era of science, we could get an adequate set of samples to high-quality labs to really advance our understanding of what it is in a more timely way, rather than just a flu-like syndrome of unknown origin and etiology. And I'm just wondering, is that happening?
So I completely agree with you. I think that it should absolutely be possible. There are still challenges. You know, one of the reasons that vaccine programs are challenging is because maintaining cold chains are challenging in many of these settings. So if you reverse that, taking samples might also be difficult. I don't know the specifics of what's happening on the ground in that setting, but it certainly feels like this should be within reach.
I mean, I think that's one example of many where we have to, as a global community, you know, just commit to mobilizing much more quickly when there's an outbreak of concern like this. But that isn't my question. But I did also to you, Dr. Metcalf, I was interested in your 3 plus a 4th areas of sort of concern. The 4th one you mentioned, I think is interesting and important. You framed it in a very optimistic way about people that have some kind of immunity from earlier exposures. I'm wondering about the other side of it, though, which I think also is really important, people who are more vulnerable because of immune deficiency from disease or undernutrition, comorbidities, and also people with just chronic disease seem from COVID to have been much more vulnerable, and we don't completely know, the mechanism of action there. But it seems to me that is an increasing concern in this country and around the world that could affect how outbreaks unfold. Also, antimicrobial resistance or inappropriate use of antibiotics over time affecting pathogens and immune response of people seems to also be potentially a player in that fourth domain of activity. So I just sort of wondered your perspective on that.
Dr. Hamburg, I feel like you're way ahead of me. But it's absolutely the case. I mean, perhaps I think you're also invoking the fact that during COVID, it was clear that the new variants, I think the evidence is now there, emerged in immunocompromised individuals. And there's deep concern around stigmatization of these individuals, but there's other paths one could consider how one shapes interactions around those individuals, immunity, vaccination around those individuals, trying to promote their immune status, etc. Knowing our landscape of immunity also pinpoints those areas of vulnerability to the individuals themselves as well as to the larger population. I also think, sort of interestingly, many of these so-called diseases of aging have an immune foundation, rooted in immunopathologies. So all of the gains we make in understanding immune system functioning, which has been called, the second most complicated thing in the galaxy, will also shed light on those pieces, right? The ways in which that long shadow of early infections plays out in later life, the ways in which our own immune system is attacking us, the more data we get on what normal looks like, we should be able to, I think that'll be a really interesting research frontier in tackling chronic diseases as well, which, as you mentioned, in an aging population is obviously really important.
Thank you. I just have to editorialize it. When I went to medical school, the immune system was really simple. There were just two branches, but now we know better.
Jim Greenwood.
Thank you. So, Dr. Metcalf, you talked about immunity to one coronavirus providing immunity against others. And I apologize if you said this in your remarks and I missed it, but does that lead to the notion of the potentiality of a universal corona vaccine?
A wonderful thought, and hopefully it should, right? We're beginning to tease apart the ways in which we can trick our immune system into looking at the parts of the viruses that are unchanging, which should provide protection against all of them. This is also, I think you're perhaps thinking also around influenza. This is one of the sort of holy grails of influenza vaccination research. I think we're getting closer. I think we're still a little ways off. The immune system is a wily thing to try and wrangle, but it's a brilliant thought, and I think it is one of the lines of research that is perhaps the most important, is developing these universal vaccines for all coronaviruses, for all influenzas. I don't think it's impossible.
I probably should stop while I'm ahead here now, but you mentioned the cold chain issue with vaccines, and I think that when you freeze a vaccine, it can reduce its potency. Can you elaborate? Is this about? This is my stupidity, but the vaccines when you freeze certain things, the water crystallizes and damages tissue, for instance. What is it about freezing vaccines that's harmful?
So you need to keep some of them cold, right? If your cold chain is broken and they lose that continuous cold exposure, then I think many of these vaccines are live attenuated vaccines, so maybe the element actually just dies, or you could denature the proteins. I think it will probably depend.
You have to keep them cold but not frozen?
I think we might need to ask an actual vaccinologist.
Okay, all right. And I just have one more question, and it's probably a silly question, but I understand. I mean, climate change is by orders of magnitude the most dire thing that we face. And I understand, I think, that why global warming is posed such a threat to so many species, because at the rate of change in the environment is faster than the rate by which they can evolve to adapt to it. But I often wonder, we have such a parade of horribles caused by global warming, and we were focusing on the health. Is there one instance where it actually is beneficial to health, or is it just like all negative?
I'm sure that
fewer people are freezing to death, I guess.
There must be, right? Because most pathogens have a sort of intermediate optimal temperature where they do bests, and countries all around the world are going to be moving all around that curve. So there'll be some places that are moved out of areas of optimality for particular pathogens. I can't think of any examples offhand. Some of my colleagues might have one.
I think malaria is one way we might be getting, some regions are so warm that you would no longer expect endemic malaria transmission in places that historically had endemic malaria transmission. The big but is those places are getting so warm that livelihoods are going to be impacted in other ways. So we're going to have reduced ability to grow agricultural crops for food. So it's a blessing and a curse. It's a small positive in a very dire context otherwise.
I'm glad that we don't give the climate deniers any ammunition here today. Billy, did you have any comment on that?
I think I mentioned before about the shift in the distribution. So you pick up at one end and lose some at the other end, and probably nets out to the same.
Thank you.
Governor Ridge.
Yes, you may not have an answer to this. I should probably talk to somebody at DOD. As we deploy our servicemen and women around the world, around the globe, and depending on where they go, they are potentially subject to multiple kinds of ailments. Are they vaccinated internally, consistent with their area of operation as they're deployed? Do we know if they are? Like if I'm going to be deployed in South America, if I'm going to be deployed, you got the question. Regardless of deployment, do we vaccinate them in advance to create some immunity to the pathogens that they might be susceptible in those regions?
Is this, so I'm sure they do. I know that, during the Ebola outbreak, one of the ability to help was really limited by an inability to vaccinate. And there was, vast investment. The US Army and others, I believe, were involved. Again, I'm not an expert on this, but I'm pretty certain that based on the current set of knowledge, the right set of vaccines would be given. That's my sense, but I don't know.
Good, thank you very much.
Actually, the commander may know the answer to that question.
All right, very good.
Vaccine protocols for
Sure.
deployment?
I mean, there are different force health protection guidelines for wherever someone may go, and if there are licensed vaccines, then yes.
Okay, I appreciate that. Question is based on personal experience. Before I was deployed to Southeast Asia, they gave us a set of shots, and it did everything except immunize us for malaria, but so be it. I just wonder if we're still, as we pick up more and more knowledge about the impact, regional impact of certain pathogens, I suspect, I'm glad you believe that we are. I hope we are trying to immunize our men and women overseas based on knowledge we have about the vulnerability they may have for being deployed in that area. So thank you very much. Thank you for your service to our government, and thanks for taking this on professionally. And we'll all ultimately benefit by the good work that you and other panelists are doing in this arena. So we thank you very much.
Dr. Shalala.
Yes, I just have one quick question. Are the data modeling tools that you're using being used by the federal government?
I would say no.
Yeah, that's my concern too.
So they're not. They know about them, though.
I think so. I mean, we're at the academic end, so we're at the innovation end as well. So we're always building new things to some extent. But
I mean, there's sort of scenario modeling hubs for COVID-19 and influenza where they asked for modeling tools. They put out a call for modeling tools from institutions around the country to submit to those modeling hubs. So
actually, yeah, and the Center for Forecasting and Analytics is essentially, yeah, exactly. So there's certainly, depends on, yeah, exactly. The federal government's intersection with academics will be using the same tools.
I would also say that in the intelligence world, there is some use of modeling because some of these events that are weather-related, for example, are then related to conflict and other things, but I don't know exactly the...
Yeah. I mean, the WOA weather modeling tools are, some of the best in the world, and it takes supercomputer activity to do that. And I think that's kind of what I was referring to is it doesn't take much more to start building in disease distribution, vulnerable host populations. The biological data can be built into those models. It's not a great leap because the weather modeling is pretty sophisticated.
And getting better.
2 million sensor data per second that they're collecting and entering into their models. So we're really, that's why I was pushing. There's an amazing opportunity. I'm not sure how to get, NOAA and DOD and NIH all working together.
And we all have silos, right? We don't always intersect with the climate scientists as much as we should. I mean, I think we're lucky. We've been lucky at Princeton in that the infectious disease modelers are talking a lot to the climate scientists, but we also see them complain about other infectious disease modelers' use of their models. Like, it's inappropriate in ways that come from not communicating.
In theory, this could be an arena that would actually bring countries and regions together, even where there's a history of conflict or distrust, because there's a common goal and benefit here. And we've seen in the weather monitoring that, the U.S. and Cuba, through thick and thin, has worked well together because there's the shared interest in better prediction of hurricanes, et cetera. But it's something to think about, but this may not be the moment to pursue it aggressively, I don't know.
I think climate and infectious diseases as well, right? The eradication of smallpox was an incredible moment of global unity where people would stop civil wars to get the doses across the bridge.
Yeah.
Senator Daschle, welcome.
Well, first, thank you. Thank you, Fred. I apologize for my inability to join you sooner, and this sounds like it's been an extremely informative panel, and I agree especially with Governor Ridge. We're very grateful to each of you for your service and your work. And if this has been covered, by all means, I can catch up later. But I'm just curious, as we address the global ramifications of the challenges we're facing with regard to these extraordinary challenges we're facing, disease globally, how much is the amount of disinformation and the vaccine hesitancy that we see now increasingly pervasive in the United States affecting global efforts to address these problems internationally? Could you address that if you haven't already done so?
It's Rachel, I think.
So I did talk about that briefly in my talk, but I think for the US context and for infectious disease context, actually anti-vaccine hesitancy is a really big concern. We have diseases that we have eradicated within the US that we are now seeing outbreaks of, and the obvious one being measles, but all vaccination rates are dropping. They're declining. It's definitely heterogeneous across the country, and there's sort of pockets and locations. For each of these diseases we have in our head, and we've developed calculations for sort of vaccine thresholds. What is the percentage of the population that we need to vaccinate in order to keep that disease eliminated? And it's based on sort of fundamental features of the pathogen. So for some of these diseases, we can afford to lose a certain percent, vaccination coverage and still be likely okay. The issue is that there are other pathogens where we really need to be hitting sort of 90%, 95% of the population vaccinated, and we're very close to that line. And again, as I said, it's heterogeneous over space. So there's pockets where it's much lower and then pockets where it's much higher. So I do think this is a real cause of concern for the US, both in the climate change context and without. And the way it's trending is definitely, I'd see it as a worsening risk over time.
Well, we have the highest death rate this year among children for lack of vaccines due to seasonal flu in our history. Never been higher. And the vaccination rate continues to decline. I worry, especially as other countries watch the United States, how they too will generate greater and greater skepticism and hesitancy. And the disinformation campaign just seems to me to be unchecked and a huge challenge. So I think it's a problem we're going to have to continue to focus on and try to address in a more meaningful way, especially maybe in the next couple of years. Thank you.
Very well said. Susan Brooks.
Very briefly, and we've touched on it, and maybe when I heard the little bit of discussion about cows, and then you mentioned white-tailed deer. Indiana is the home of largest producers of ducks and turkeys and so forth. Can you talk a little bit about connecting this discussion with our food security? and the impacts of what we're talking about relative to food security, because I think that's something everyone, whether they're anti-vaxxers or vaxxers, care about. How should we be looking at issues around food security?
I think with great concern. I do think that, we sort of know many of the things we should be doing. For example, vaccination, for example, hygiene, for example, sharing data. It is astonishing how little data has flown out of the dairy farms, and this seems to be an issue that's been going for a while. It's very hard to know how diseased cows are moving. It's very hard to know what risks of infection are, or look at sequences, etc. So I think we need information, and we need consideration of vaccination as a really important tool, investment and policies around vaccination. Till recently, it was very hard to vaccinate some animals for some diseases because it was impossible to distinguish serologically by immunity whether that animal had had the disease or had the vaccine, right? So suddenly you could no longer trade if you had vaccinated against, for example, I forget, Newcastle's disease or something. But we have the ability to develop vaccines where this is no longer the case, so that barrier shouldn't be there. And a vaccination is a clear path to reducing risks of infection. I think, yeah.
Yes, I mean, there's some high-level conversations. One is just how we call things. So the minute you call it bird flu, then it's supposed to be the bird people dealing with the problem, even though it affects cows or humans, and we break all that up. So that gets into that. We're trying to assign it to an agency rather than dealing with the actual problem. So that's kind of the high level. But I think also, it's like, what's in it for on the ground? What's in it for the farmer? So really, our systems, some of the systems are farmer directed, and then some are more about, can we gather this information so we can make next year's vaccine? Somehow those have to be integrated. But I think we tend to, especially at a higher level, we tend to forget about what's in it for the farmer, what's in it for the local citizen or the private citizen. So we really kind of got to get back to those roots. And I think Dr. Kerry was, earlier this morning, that community outreach, that engagement has to be in the agricultural community. It's with farmers and ranchers, and they need to feel a part of the health system, and they contribute as much to health as medical doctors do. But, so we need to make everybody in society, it's an all-of-society approach. Health belongs to society, and the medical profession is there to help. It's not that health belongs to the medical profession, it really belongs to everybody. And so I think changing that kind of attitude and that dynamic about who is health for, well, it's for everybody, it's for people.
I would just add sort of a separate point, but the livelihood of people in the agricultural world is increasingly under threat from climate change as well. So not only is this health piece, and we're worried about the risk of climate on infectious disease, but just in terms of climate change impacts, we know this impacts the food system. The uncertainty and variability, which is increasing in the climate change, makes it increasingly difficult for farmers to maintain and ensure their livelihood going forward. So we can have sort of massive crop loss if the wrong set of events or the heat waves occur. So I think farmers are in this difficult position where they're being pushed from multiple sides, and the risk from climate change is definitely sort of coming to a head for people whose livelihoods who depend on that sort of income stream.
Okay, good afternoon. Good afternoon. I hope everyone enjoyed lunch. Thank you so very much for returning. I have the honor of leading this last and final panel, and we are going to work hard to have a hard stop by 3 o'clock. There's some trains to catch, trains, planes, automobiles to get to. So with that, we have a very distinguished panel. It's going to be focusing a bit on national security. We're going to start with Ashwin Vasan, who is Dr. Vasan is the former commissioner of the New York City Department of Health and Mental Hygiene. So thank you for being here today. Then we have Jeff Schlegelmilch. Did I get it? Yes. And he is actually born in Indiana, I just learned. Director of the National Center for Disaster Preparedness, Columbia Climate School, Adjunct Associate Professor of Climate at the Columbia Climate School. So welcome. And last but certainly not least, Dr. Ann Kurth, who is the president of the New York Academy of Medicine. So it's wonderful to have, some local and state authorities here to really help us get started. So we're going to start with you, Dr. Vasson, if you'd like to make your opening remarks. Thank you.
Wonderful. Thank you, Representative Brooks. Thank you to the esteemed panel. Thank you especially to Peggy Hamburg, my predecessor as commissioner a few years back, we'll say.
Many.
And and thank you for inviting me today. It's great to be here. What I hope to do today is kind of offer up a perspective from New York City, where I just had the honor of completing my tenure of nearly 3 years as Commissioner of Health, but as a model for what it looks like to confront prevailing climate threats, and also where that leaves us in our current state of preparedness against biothreats, whether they be natural, accidental, or engineered in nature. I want to thank my colleagues at the New York City Health Department first, and others like Dr. Ashish Jha and his partners at Livermore Labs, who I worked with a little bit on this presentation. COVID was not just a health crisis, as you know. It was really a stark warning about our vulnerabilities. It took us months 4 years ago to identify SARS-CoV-2, that it was spreading across our country, and it exposed some fundamental weaknesses in our ability to detect and understand and respond to biological threats. And in New York City, the impact was, of course, stunning. Of the 50,000 people or so that we tragically lost to COVID, half of those occurred in the first 3 months because of those delays, making that a uniquely painful and traumatizing event for this city where I've lived and where I call home. And then successive waves of COVID, new threats like Mpox, the first case of polio in New York in 2 decades brought to the fore some strengths, some growing strengths, but also some weaknesses and challenges to our biothreat surveillance and preparedness system. So underpinning all of this is what I'll try to do today in my remarks, which is to describe how climate is impacting the health of New Yorkers and how that's an exemplar for the country and the world, how our city health apparatus and government has responded in turn, including and especially innovations in data systems that underpin our response. Relate that to our current state of preparedness in the city, again, as a model for the country. And I would just preface all of this by saying New York City's in a much better state than many, many jurisdictions in the country. We have an extraordinarily well-resourced public health system, relatively speaking. We have a great public hospital system, safety net system that supports us in these efforts. And we've got a commitment to public health that is generations old, which puts us in good stead. We're able to recruit extraordinary talent to this city to do this work as well. So if we are facing these challenges, just imagine what's happening in other parts of the country, which many of you are well aware of. And I'd like to end by offering a potential framework for a way forward with New York City as an incubator for a new national biosurveillance infrastructure, moving from a reactive approach and an event-based approach to one that is much more proactive and predictive, grounded on the much more routine collection of a wide berth of data and tailored to meet an evolving threat landscape. Every year in New York City, we lose more than 350 people to heat-related causes. It's the leading climate-related health issue in our city. We had in 2024, this past summer, the highest number of extreme and elevated heat-related days and advisories than we've ever had before. This is not a new phenomenon. And as a result, in 2015, we developed something called the Heat Vulnerability Index to inform neighborhood-level policies and programs that send life-saving resources to where they're needed most, ensuring that the work is focused on neighborhoods with, for example, the least tree cover, or the least amount of green space, or least access to public transportation, or the greatest structural and economic inequities like income and wealth, which impedes energy and cooling access, for example. We've used the HVI, as it's called, along with other metrics to inform efforts, for example, like distribution of simple things like air conditioners, where in high HVI neighborhoods, access can be as low as 75% compared to a citywide average that's much more than 90%. This is life and death in an extreme heat event, air conditioning. Something as simple as that is life and death. And we've used these data to secure free AC units to over 70,000 older low-income residents of these high HVI neighborhoods, and also to secure over $70 million in partnership with the state in summer utility subsidies to reduce energy costs at a time when we know that people need to be running cooling in their environment. So we need to be exploring at state and local levels much more of these kinds of policies. Warming temperatures, of course, lead to more extreme weather, as we saw recently in hurricanes Milton and Helene, leading to extreme flooding and overwhelming of our aging infrastructure in a city like New York. In September 2021, 13 people, including tragically a 2-year-old boy, died of the effects of extreme flooding from the remnants of Hurricane Ida that put our sewer system and aging buildings in extremis. And we, while we have evacuation plans and outreach and prevention, we're left to do post-mortem morbidity and mortality analyses to kind of really develop a predictive map, because we are so far behind in a city like this that is older and has aging infrastructure. We're grateful for things like the Bipartisan Infrastructure Act, where we've started to invest in resilient infrastructure, but we have much more to do. Warming temperatures are, of course, leading to shifting mosquito and vector-borne disease patterns. We have probably the most robust mosquito surveillance and control system in the country based on our hard-won experience from West Nile virus, which appeared in our city in 1999. We do routine testing of hundreds of pools across our city for West Nile and other illnesses. We do larval control spray operations all across the city, and we're doing it for longer and longer time periods because the seasons are changing. And we're starting to look for new infections that will rear their head. Dengue is on our horizon. We haven't had a first locally transmitted case, but I'm sure it's to come. And we've, of course, had our first malaria cases in 20 years locally transmitted in the United States. And air quality. Many of you were here on the Eastern Seaboard and here in New York when our air quality rapidly deteriorated to the levels of cities like Delhi and Lagos and others. And we have the largest urban air quality survey, NICAS, which complements our EPA sensors, hundreds of low-level sensors to complement all these sensors from the EPA at the top of skyscrapers, combined to give us a very granular pattern of which neighborhoods are at most risk of the effects of worsening air quality. What does that allow us to do? It allows us to send out masks, issue guidance, and protect essential workers who can't afford to be indoors during an air quality event. So it's clear that it's having real world impacts. And on the positive side, I've outlined a couple of things that we're doing that could be examples for how other jurisdictions, states and localities step up. We've also talked today, and I heard Dr. Kerry and others say, the need for integrated data is real. The need for us to bring in healthcare, payer, claims, community, and public health surveillance data into one single view is essential for planning and response, both for chronic health challenges as well as for acute emergencies. And so last year we built a Center for Population Health Data Science based at the city in partnership with Microsoft, because we know we have the technology and we know what to do. It's really a governance, political will, and cooperation issue where we're now starting to get EHR data, health information exchange data, claims data, and surveillance data into one single view for conditions that are both reportable as well as voluntary chronic conditions. We have much more to do. Most of our active threat surveillance for airborne attacks or airborne threats is very reactive in nature. You know BioWatch, you know the challenges of that system. My agency administers BioWatch in the city. we have to build the modern version of BioWatch. And what does that leverage? Number one, it leverages data that we collect from a much broader array of sources. It cannot just be point estimate capture of samples. We have to be merging data from wastewater, not just from municipal sources, but also from hospital and healthcare facilities, transit hubs, and VA facilities. We need de-identified blood samples and urine tests collected from labs. Over 70% of US clinical samples are analyzed at commercial labs. We need to be partnering with Quest and BioReference and folks like that to get de-identified samples from them. We need better access for EHR data and to finally successfully leverage meaningful use into our CDC surveillance systems. We need to enhance our traveler genomic surveillance program that asks people to volunteer to be swabbed, and that should be expanded to other ports of entry, not just a few, and to expand to mass gatherings as well. We need to incorporate non-human data from the USDA and from veterinary clinics as well to be able to look at our animal risk and the risk of spillover effects, and many, many more sources. The reason I'm outlining these different data sources is that we need to move beyond a signal that is captured through one static data set to a dynamic way in which we're merging all sorts of types of data and using artificial intelligence to do much stronger and routine predictive that runs in the background, predictive analytics. If we can develop community profiles of health, what the baseline is, then we know what perturbations from that baseline look like, and we can actually be responding in real time to see, is that a real threat, or is that something that we can dismiss in the background? Right now, what happens is if we do get a signal of any kind, whether it's through our ED surveillance system or through something like BioWatch, what ends up happening is frankly, mostly a communications and political discussion of whether we want to raise this to the level of a threat, rather than saying we've got enough data to bring it together and enough data to predict what is the risk of this actually being a threat. There's too much room for human error and human judgment right now, and I'd like to see us leverage much more of the technology that's already available to us to protect our security and health. I know I'm out of time. I ran over. I'm sorry. I thought it was 9 minutes. I think it was shortened, but I'll turn it over to my colleagues.
Thank you, Dr.
Thanks.
Weston. Next, Mr. Schlegelman.
Great, thank you. Thank you, excuse me, and thank you for the opportunity to be here, and for all of the great work that this commission has done, and for shedding light on this important topic. I'm going to step back a little bit and talk about sort of the broader emergency management systems that we have, particularly on the front lines of climate adaptation, for keeping that water back, for creating that cooling infrastructure. And one of the challenges that we have is for disaster assistance. It's much like the work that this commission has uncovered for biodefense. So in disaster assistance and disaster recovery and relief, there are as many as 90 different programs across 30 different agencies. There's significant overlap in programs. There's significant gaps between programs. There are some that are activated by the Stafford Act and disaster declarations, and others that are independent of that. And it creates what a colleague of mine in the federal government calls a Jenga of federal assistance that is layered on top of every disaster. But further, particularly agencies like FEMA that, particularly under this administration, but not exclusively, are working towards integrating climate change, are still fundamentally designed as consequence management agencies. I'll give a very specific example. When Pete Gaynor was being confirmed as FEMA administrator, and I have nothing against Pete Gaynor, he's a perfectly good professional in this, was asked a question to stoke some political coals. It said, do you believe that climate change is making disasters worse, right? And this is in an environment where no matter what you say, half the people are gonna be mad at you, or just over half. Anyway, so he said, it's not the role of the FEMA administrator to, or something to the effect of, it's not the role of the FEMA administrator to determine the cause of disasters, but to manage the consequences. Again, I have no problem with Pete Gaynor. I have no problem with him giving that answer to survive that political gauntlet that was thrown down. I do have a problem with that being a perfectly acceptable answer in the laws of the United States. That our disaster management agencies are absolutely front and center with doing this, but don't necessarily have the authority or the mandate to do this. And this is evident as well, too, in terms of how sort of FEMA has evolved in the use of the Disaster Relief Fund. It was really designed to handle one or maybe a few major disaster recoveries at any given time. Currently, there's more than 100 different disaster declarations that are being addressed. Some of those are multiple ones under a large event like Hurricane Harvey or something like that. Most mitigation funding that is really needed to sort of bolster our resilience to climate change comes after a disaster, comes after a major disaster declaration. There's some exceptions, including the Building Resilient Infrastructure and Communities program, which is interesting, having passed through legislation under the Trump administration and being leveraged for climate change under the Biden administration. But that's very, very small compared to the amount of post-disaster funding that comes. So we have to wait for it to be destroyed before building it better. The Bipartisan Infrastructure Law and the Inflation Reduction Act have both created significant funding sources, but those are one-offs, right, or for a couple of years, and then there's concerns of some of that being clawed back. Some analyses from the Congressional Research Service and others on FEMA and climate change finds it particularly problematic when it comes to slow onset disasters, as well as things like heat and others. Compounding events. Essentially, it's designed around being able to have, and a similar problem in health is what is the direct effect. We're not very good at looking at second or third order effects. And our disaster relief legislation and authorization is trying to make a direct connection. This hurricane damaged this house, not this hurricane followed by this flooding event, followed by this heat event. And slow onset disasters further compound that. In addition, we do have mechanisms, the National Flood Insurance Program, the flood maps, the National Risk Index. They do not contain climate change projections. And they're used as a basis for evaluating risk on where people build and in some cases their insurance rates. We don't include climate change in those projections. There has been work being done and we expect that work to halt. So we don't really have a national clearinghouse. I will say too, there isn't necessarily consensus among models, as there never is, whether it's weather models or pandemic epidemiological models. But there really is an opportunity for agencies like FEMA to be authorized and funded to take more of a leadership role in convening, validating, and arbitrating these risk models. So integrating all of this into legislation is particularly important. As I mentioned, there are vehicles that were created under the Trump administration that are being utilized by the Biden administration, but that are likely to be reversed or called something else. So without this being codified in legislation, it's subject to the whims of the political office, of whatever the politics of the day are. And we see that swing back and forth. And as many of my colleagues have said today, we need continuity. But now I want to talk about why none of what I just said really matters. Because this notion of scientific knowledge informing decision-making and collegial legislative processes are going out of style. After 9/11, we saw the largest restructuring of the federal government since World War II. After Hurricanes Katrina and the emergence of highly pathogenic influenza, H5N1, we saw the Post-Katrina Emergency Management Reform Act, we saw the Pandemic and All Hazards Preparedness Act, among many other acts in that time span, fundamentally evolving the agencies towards 21st century threats. After Harvey and Maria and Hurricane Florence, we saw the Disaster Recovery and Reform Act, a little more technocratic, but created some of the pathways that we're using. After COVID, crickets. Nobody's holding hearings. I understand this commission has. I'm speaking in terms of the federal legislative process. We're seeing sort of legislation introduced, then pulled back. At one point, there was something from the White House about a moonshot. A colleague and I looked at it. It didn't get us to the moon. It really more got us to the Air and Space Museum. So we're struggling to remain relevant amidst an increasingly political environment and politically motivated assaults on science and scientists. And this is coming from domestic as well as foreign actors. Health officials have faced harassment, death threats. Some have left the field. Many have retired. Some have lost their lives during the pandemic. Many of the after-action processes I've been involved in talking with health officials, they talk about this plague of mental health issues going unaddressed, a dearth of leaders leading in retirement. And even when those positions are replaced, when you lose one of those leaders, you're losing, in some cases, decades of experience in the field. At the same time, we're also seeing public health authorities eroding. Public health authorities that were used to help stem infections during the pandemic, the acute phases of the pandemic that will not be available in the future. And I can say that by any measure, inclusive of those items, we are less prepared for a pandemic today than we were 5 years ago. We have lost staffing, we have lost authorities, and as a nation, we seem to have lost the will to save lives. Climate science suffers the same pathology. Meteorologists are constantly harassed for reporting on climate change. A Global Witness survey found that 39% of climate scientists report online harassment. For those who have published more than 10 academic papers, that number goes up to 50%. Of those, half of them report feeling anxiety, loss of productivity, and about a quarter of those experiencing depression. Many of my friends and colleagues are afraid for their jobs in the coming 4 years. Some of them are afraid for their lives. Unregulated quasi-news outlets are becoming go-to sources for information that are often suppressing scientific information, elevating misinformation, and focusing harassment towards individuals. Just in the last 2 weeks, Elon Musk publicized the names of government climate scientists, career professionals, in roles questioning their legitimacy and whether they're worth the taxpayer dollars, unleashing the hordes of Twitter or X or whatever the hell it's called now towards these people. Many of them deleted their online accounts, have talked about their lives being forever changed under constant threat. We're also seeing accounts linked to foreign states spreading misinformation in disaster situations across a wide range of topics. The Sabin Center for Climate Law at the Columbia Law School hosts the Silencing Science Tracker. This tracker is a joint initiative with the Climate Science Legal Defense Fund. Since 2016, it has logged over 544 state and national actions to suppress scientific information at federal and state levels. This includes government censorship, interference with education, personnel changes, research hindrance, bias and misrepresentation, and budget cuts. We knew the dangers of the pandemic long before COVID-19 emerged. There were numerous forecasts of the shortages of personal protective equipment from SARS-1, H5N1, H1N1. There were numerous calls of action to spur vaccine development. We knew we would fall short of ventilators. We knew the disruption to supply chains a pandemic would cause. Many of us who have been in this field and working on pandemics weren't all that surprised. The data was there, we didn't use it, and millions suffered as a result of it. We have an abundance of data on climate change and impacts. We need more, but we are not being held back by the lack of science. We're being held back by the denial of science, the assault on scientists, and the proliferation of misinformation. Data is useless without action, and I implore you and leave you as a bipartisan commission to take a stand where others have cowered. Call out this existential threat that is fomenting and stand up in a unified voice and say stop. Thank you for the time, and I look forward to your questions.
Thank you. Thank you for that testimony. Dr. Kurth.
Chairpersons and esteemed commissioners, thank you for your leadership on this topic, and I appreciate that you are holding this session on this critical issue in New York here today. Those of us who were here during Sandy, I myself was at NYU, remember that we had nurses in the NICU were bagging babies down dark hallways, putting them in taxi cabs to put them to higher ground throughout the city. We can and must do better, and even at this very sobering time, I believe that there are specific actions we can take and that the Commission can consider recommending. So I'm going to move from that very sobering assessment, which is certainly the case, to make some specific potential suggestions about how, following Dr. Kerry's theme on the importance of health systems, public health systems, and the workforce, we might consider protecting population health and strengthening national security. And one of the, I think, terrific strengths of the Commission is that you do have a bias to action. So as we think about the rising temperatures, the extreme weather events, the spread of infectious diseases, and the increased chronic disease burden, which includes mental health stresses, disruption of supply chains, these all threaten, of course, the resilience of our health systems. The World Economic Forum has predicted that by mid-century, the climate crisis will cause an additional 14.5 million deaths, 12.5 trillion in economic losses, and 1.1 trillion in extra costs to healthcare systems around the globe. By that same mid-century measure, we could have flooding taking 8.5 million lives, drought taking 3.2 million lives, and the impact on economies, which as we've discussed, is both direct and indirect, including heat waves with at least 7 trillion lost to productivity and additional deaths. So what can we do? Because I think that is the hope and the goal. As we think about the emerging infectious and NCD burden and the impact on the health infrastructure, we can think particularly about the impact on outdoor workers with heat, and that includes, of course, soldiers as we think about our workforces. We've talked about there's actually an increase in intra and interpersonal violence as we see temperatures rising in aggregate. The mental health sequelae of all of this, not just climate anxiety, but PTSD, is going to take place in a behavioral services sector that is already extremely stressed. Population displacement, both from acute events and from longer-term managed retreat, which will be coming in coastal areas, means that we have to get better at delivering mobile health care capacity, having distributed electronic health record access, distributed supply chain, workforce disruption, and movement. So we should be making more investments in climate-smart health surveillance that weaves together nationwide epidemiologic, climate, agricultural, and environmental information systems and moves faster towards response and mitigation. At the local level, both city, county, state level, integrating real-time data from environmental and health sectors can help us predict and respond to those outbreaks, heat waves, particulate pollution. New York City, for example, we had the Canadian wildfires, the wonderful orange sunsets that someone mentioned. It doubled our ED visits for asthma the next day. This can now be routinely anticipated and should be. The health workforce is already stretched. We know that we anticipate shortages for our physicians and nurses alone in the six figures. Globally, we have at least 10 million shortfall in health professionals. We have existing primary care and rural shortages that are only going to grow in the coming years, and the climate-induced and exacerbated disasters will further strain capacity. So we've got to do that workforce preparation, both for surge demand and for a better equipped workforce with knowledge of how to address climate change with their patients and populations. That could involve expanding federal funding for climate-focused workforce training and incentives for providers to practice in underserved areas, particularly those that will be most affected by climate change. We need to leverage technology, as we've discussed, and that includes for telehealth and healthcare delivery, and that can be a lifeline, of course, during disasters, but also requires robust infrastructure, regulatory support, and continuous reimbursement models. So looking at those policies around telehealth licensure and also reimbursement, I would urge the Commission to consider. Supply chain and essential medicine security, obviously climate disruption will have an impact there. We need to make our supply chains more climate resilient, incentivize domestic manufacturing of critical health supplies, and develop stockpiles for climate sensitive areas. Finally, community-based health resilience is a crucial aspect of biosecurity. We need that deeper preparedness at the local level, and that can include community-driven public health initiatives. One example includes the CDC has a new PHS Preparedness Center initiative across all 10 regions in the U.S. Funding for climate-resilient health facilities. We've talked about the IRA and its ability to move health systems towards better mitigation and energy use, and also ability to adapt to extreme weather events. Telehealth and resilience hubs in communities themselves is also another approach. So as we think about the next 4 years, as well as the next crucial decade of action here, it may be important to focus on strategies that emphasize economic growth, deregulation, public-private partnerships, and of course, national security, which the Commission is crucial for. Some specific health workforce regulation changes that might enhance resilience and responsiveness to climate and health disasters could include interstate licensure portability. So implementing a national licensure compact for health professionals, similar to the interstate medical licensure compact, can allow health workers to travel, practice and travel across state lines during emergencies without regulatory delays. There could be mandated or at least standardized climate and disaster preparedness training in health workforce programs. We do need to continue, as I said, to incentivize rural and underserved area placements, including loan forgiveness program expansion, financial incentives for health professionals to work in these areas that will be and already are disproportionately affected by climate crisis. Flexible staffing models for disaster response. And of course, we tend to think in the acute model, but these acute events accumulate, and there also is the overall increased burden of climate accelerated NCDs. So we do have to think about ambulatory care as well. credentialing and onboarding of streamlining, onboarding for expedited credentialing during emergencies and temporary health workers. Mental health support. We've talked about the impact of mental health both on our populations as well as on health workers themselves. This needs to be accessible both before and after disasters and on an ongoing basis. We've talked a bit about data, the need for data systems. Data-driven workforce deployment would be needed to both look at workforce availability projections and look for deployment. Expanding scope of practice, expanding the scope of practice for health professionals, for example, nurse practitioners and physician assistants and others, not only during emergencies, but to address the growing primary care and NCD crisis would be welcome. Finally, public-private partner workforce partnerships, encourage partnerships with private health entities to create reserve pools of trained professionals who can be deployed in disaster scenarios. Now, there'll be, of course, barriers to enacting some of this, but I think some of the strategies that you might creatively come up with would be to expand those compacts, potentially suggest that Congress mandate permanent telehealth reimbursement parity, and include additional funding. Certainly the IRA has been helpful, but look for more continuous funding. Look at incentivizing emergency scope of practice expansion through things like public health emergency preparedness grants. Include climate resilience training into federal programs like HRSA grants. Expand credentialing during emergencies through the Public Health Service Act. Broadband funding is something to look at through the Infrastructure Jobs Act. Dedicated funding streams for workforce mental health support, like the Behavioral Health Workforce and Education Initiative. Expanding the workforce data integration, like with the National Health Service Corps. And looking, again, always to build those bipartisan coalitions where we can, because these reforms are necessary for national security. So in conclusion, obviously, climate change is here. Its impact on biosecurity is escalating. By acting now, we can transform our healthcare and public health systems, which need to be better integrated, into a more resilient, adaptable force capable of safeguarding our population health. Urge the Commission to support policies, in summary, that prioritize telehealth structure, workforce development, supply chain resilience, and enhance disease surveillance. Together, we can protect the health of every American, as well as our colleagues around the world, and ensure our biosecurity in what is very clearly a stochastic future. Thank you.
Thank you, Dr. Kurth. Question for Dr. Vossen, probably, and Mr. Schlegelmilch. What would you say are a couple of ways that federal government can work better with state and local governments with respect to disaster response? A couple of, we like trying to come up with specific ways.
Well, as I alluded to, but didn't quite complete in my remarks, we need more investment into aggregated, integrated data systems so we have a more complete picture of threat assessment and so that we can have better discriminatory power on signal versus noise, right? As I alluded to, there's a lot of human error in that decision. So how do we do that? The CDC liberated a very small amount of money for data modernization. We in New York then matched that with local dollars, significantly more local dollars to build out the center that I described. How can we get more federal investment into core data infrastructure at an area level, whether that's state level monitoring or city level monitoring? And I'm encouraged by your state, Congresswoman. What Indiana did to expand public health funding at a community level on the service side must be matched with investments on the data side. We're here talking about biodefense, and I think without a sound data architecture, our ability to actually decide what is and isn't a threat remains extremely poor in its current state. So federal investment into integrated data architecture. And the last thing I'll say is we know what to do in terms of the technology. We've got partners out there that are already partnering with federal agencies. We've got local partnerships like the one I described. There's no shortage of the engineering capacity and the informatics capacity. What we haven't done is imbued that and imbibe that into the federal system in a consistent way. This could be a central data architecture, or it could be a regional federated system, but it has to be modular and standardized in such a way that we can look across regions and say, and look across states and say, okay, there's comparability here.
Thank you. Any other ideas?
Yeah, a couple of them. One is, so I mentioned before some of these grants for disaster mitigation, climate adaptation, the building resilient infrastructure in communities is one. One of the key challenges with that grant is it's a competitive grant. And there's a cost share involved, but there's some mechanisms for impoverished communities to waive that cost share, but you still have to have the administrative capacity to apply for the grant. It's no easy task, right? Okay, I see some reactions here, yeah. For folks who have written grants and knowing that applying for a disaster mitigation grant, it often costs a lot of money just to get to the point where you can get there. And I've had state mitigation officers talk to me lamenting about how some of the most in-need communities can't even start the application. So I think really taking a hard look at, I'm not saying to do away with competitive grants, but formula grants do have a benefit in being able to get to hard-hit areas without necessarily creating that barrier to entry. And so that needs to be looked at more closely, is sort of the equity across areas that are accessing these. And then the other is I think that there are some areas where the federal government has been a leader in terms of scientific information. We see it with like the National Hurricane Center and with meteorological data. And you still have regional and state offices that sort of feed off of that, but that promotes that standard. We have it to a certain extent in the health space with Health and Human Services, with the CDC, with much to debate about around the edges there. We don't really have that for disaster risk management. We don't really have that particularly for the integration of climate models and different methodologies. And I think that there's a tremendous opportunity for FEMA or a similar, perhaps a structure within FEMA, perhaps something independent that serves as sort of that nexus of climate analytic information for the purposes of infrastructure analysis, for the purposes of insurance risk, and looking at the different models, validating the different models. But right now it's a little bit of the Wild West out there with some proprietary behind corporate iron curtains and some among academics who will debate for hours over whose is better, and the answer is probably they're both pretty good for different uses. So we don't have that national leadership that I think would be tremendously beneficial.
Thank you. Dr. Hamburg.
Well, thank you very much. Really interesting presentations, and all from people that I know have gotten their hands dirty working on these issues, but also doing their on-the-ground work, always with a mind to the larger context in which this work is being done and the opportunity for broader application. And the old sort of phrase about if you can do it here, meaning New York City, you can do it anywhere. Although that sometimes worked against me when I was health commissioner, because sometimes
that's Frank Sinatra's line, isn't
it? People didn't always want to give money to New York City because they thought it was bound to fail, and give it to another place where it wouldn't be quite as complicated. One of the things I wanted to ask about is, we've sort of evolved into a system where we have sort of what we do, day to day routinely, and then systems for crisis, funding streams for crisis, special authorities in a crisis, and there's clearly value in that. But I also think we have enough experience to know that there's certain things that actually just improve our ability to do things routinely if some of those emergency-related authorities were put in place. The data issues, CDC actually doesn't routinely have the authority to ask states for certain information in a timely way. During COVID, that became, a huge obstacle, and things improved with some emergency actions, but, then you return to the status quo. And I was interested, I should say, Dr. Kurth, in your comment about interstate licensure portability. I mean, is there a reason not to think about that on a routine basis as well? I mean, so I would love each of you from slightly different perspectives just to comment on the question of, are there maybe, just a couple of things where you can identify where there's an emergency authorization or capability that you would like to see embedded in routine? I mean, I think telehealth is another one where, we've already regressed back to some of the old ways of doing business to the harm of patients and efficiency of the healthcare system, I think. So maybe Ashwin?
Yeah, sure. I'll stay on the theme of data because I think you can't make smart decisions without good integrated data. You know very well we have a mandated reportable disease framework. In New York City, that's about 100 conditions, mostly acute infectious threats. But then we've got a whole host of other things that are our pressing health issues, things like opioid overdoses or overdoses in general, mental health conditions, for which we, as the city's health authority, are not either obliged to nor sort of destined to get anyone's data. We have to beg and borrow and steal and collect our own and then try to come up with the picture of what's happening in our city. And often that picture is pretty far out of date. And so you're doing planning and resource allocation and deployment of investments and people and capital of different forms into communities based on data that's old, right? How do we make that more real time and more in line with how we respond to emergency conditions or federally reported, federally mandated, state mandated, locally mandated, reportable conditions? So what we've done here is to say, I can't mandate you, health system X or payer Y or community group Z, to give me your data. But what I can do is figure out what are the issues you're facing in your community or in your operating model or in your institution that can only be solved when you're able to match data to other data sets you don't have access to and that the city holds. And what we have found is that there are some early adopters out there, some health systems that are forward thinking about, for example, they want to do more community cancer screening. They want to do more deployment of childhood vaccine, mobile deployment of childhood vaccines outside of the routine pediatrician's office. These are all chronic, routine health issues for which better integrated data will help them do their job better. But if we have that report, if we have that data framework, it helps me and the city do, or it used to help me, not anymore, but it will help government deploy their resources in an emergency in more effective and more targeted ways. And it's that lack of data intelligence that really slows us down. And so how do we have a solid conversation about what that looks like from a data governance, data administration, and technology perspective, while also having a sound discussion about privacy protections, disaggregation of data, de-identification of data, so that we can find that happy medium of getting government, ultimately the sort of institutionally agnostic population, emergency and health authority to get the data it needs to make the smartest decisions possible. I think in that way, there are exemplars that we should be thinking about as models for the country, whether it's here in New York City, Dallas, Texas is doing some very interesting work on this front. And then there are states like California that have pushed things along on that front as well. So I do think we need to be thinking more creatively about what our data governance is and data leadership is. It's essential.
And I think you raise a great point, Dr. Hammer. What are those lessons that we learned during COVID that we should continue and memorialize? And certainly as we think about just efficiencies in healthcare delivery, period. First of all, we know that the sector contributes 8.5% of greenhouse gas emissions. If we were able to shift to care to more prevention-based focus, more convenience, there will be higher access, as we see with telehealth. Then if we can reduce, frankly, the overall utilization of healthcare in general, it's going to have a virtuous cycle of reducing greenhouse gas emissions, as well as making a healthier population. So thinking about continuing things like scope of practice should be distributed most effectively across the U.S. and across cadres just to deliver the care that's needed, as opposed to lifting those regulations only during a COVID crisis, where the care delivered was high quality, by the way, and then going back to the old way of doing it afterwards. So I do think we need to think about memorializing ways that will allow us to deliver more primary care, more prevention, because then when you reduce acute care delivery, you're reducing overall energy utilization and greenhouse gas emissions, which goes to the broader cause.
And I think it's an important point, right? How do you reconcile the complexity post-event with sort of the blue sky, like pushing things through sort of pre-event? And that's typically what we find, is that when things are able to leverage how we do things, those models on a daily basis. We've seen it with colleagues in health. When emergency funding is pushed through, if we push it through the Public Health Emergency Preparedness Program, the Hospital Preparedness Program, sort of the existing grant mechanisms, then there's sort of an administrative efficiency, right, in terms of pushing through these vehicles that exist, whereas states that are waiting for Congress to push through community development block grants, whenever they come back and start legislating for Helene and Milton for additional funds, they're going to have to set up new structures and new procedures for all of that. The other thing I would say too, though, is that it also sort of runs into some of the incentives of governance. And my colleague, Dr. Ellen Carlin, and I write about this and looked at this extensively in our book, Catastrophic Incentives. There's business models and incentive structures in place that tend to favor complex action after disasters rather than proactive action. And I guess what I would say too is that, you know, one of the biggest themes we hear again and again and again is simplifying, right? Simplifying. And I'll give one example, and I mean this in an endearing way to my colleagues who in front of me who have served in Congress. Which committee would you ask to give up their jurisdiction over the Department of Homeland Security to simplify and make things more efficient? It's a much taller order to actually sort of work through those political incentives, but I think we have to be honest on what they are because it's the only way we'll get it done.
Thank you, we understand. Congressman Greenwood.
Thank you. So, Dr. Vassan, you gave an extensive list of things that New York City has done, a very impressive list of things it's done. My question for you is, to what extent is New York integrated with other urban areas, large cities, in two ways? One, to just share state of the art, what can you learn, what can one city learn from another? And the other one is what you talked about is the integrated data architecture, which I think is probably not going to be funded by the federal government anytime soon. And so you talked about regional alternatives to that. And could you elaborate on those two things, the extent to which you're networking and could possibly network on this data architecture?
Yeah, it's a great question. So one is thankfully we are well networked both nationally and internationally with other big cities. So one of our former health commissioners here in New York City, Tom Frieden, who went on to be CDC director, helped set up something called the Big Cities Health Coalition. It was started.
Did that actually?
Did you do that? I thought it was Tom. Oh, nice. Forgive me. So that's my fail. So Peggy set up the Big Cities Health Coalition, which is quite active today.
But he's responsible for everything that went wrong with it.
That's correct. Yes.
It was only 10 cities when it
yes, and I think it's on the order of 30 now.
Yeah.
And so
American cities?
American cities, yes,
Okay.
yes, domestic, and it has to hit a certain size threshold. I believe it's 300,000 or something like that. In any event, we have a pretty robust dialogue, and there's resource asymmetries through all of these jurisdictions. There's obviously different governance patterns. This is obviously a strong executive model. LA is a county supervision model, for example. So different governance, but we are well networked in sharing best practices, and we did a ton of that, especially during COVID, MPOX, and during emergencies, but now we're doing so more routinely. We're a part of the C40 and also the the Bloomberg Healthy Cities Coalition. I think I'm saying that correctly. And so Partnership for Healthy Cities. And so we do have a lot of exposure to other jurisdictions thinking about this. When I was commissioner and we were building up this data architecture that I described, we found that our colleagues in the London regional office of the NHS were doing the same sort of thing. And in fact, as you might have read in the New York Times, they actually contracted a lot of that out to Palantir, a third party. And we shared a lot of best practices around engaging the private sector to develop permanent technology for the public sector. So there's no shortage of dialogue. And I do think, to your second question, you're right that we don't see any major bipartisan health data infrastructure law coming to bear in the near term. So how do we start to mobilize resources of our own? We took that CDC data modernization money and we basically tripled it with our own internal budget. And there is budget in bigger cities like ours to do exactly that. Now, in the smaller jurisdictions, how do we start to regionalize that? What we've been thinking about here in the Northeast is using groups like the Regional Plan, which is our kind of health and civic regional organization for the tri-state area, and start to say, well, okay, how do we take a relatively low resource jurisdiction and a high one like New York and actually start to share not just maybe money, but also talent and capacity building and to share data in that way? How do we outsource and off-source some of the data and analytics to the city for smaller jurisdictions in the metropolitan area and the tri-state area? So we are exploring those things. I do think that what would be helpful from the federal government or federal leaders is to at least create some standards and some modularity to what these systems should have, so that we're not once again developing a patchwork where we'll have to come back and stitch it all together one day when we do have more progressive leadership in charge.
Dr. Shalala.
I'm interested in your comments about putting in air conditioners. 70,000 is a drop in the bucket in New York City. What is the public housing requirements on air conditioning? And are there codes now in the city that require air conditioning for new buildings, particularly for affordable housing?
Yeah, so what I didn't say in my comments was those 70,000 were focused on NYCHA, New York City Housing Authority complexes, which also happen to be in these high heat vulnerability index neighborhoods. So the majority of those 70,000 went to older adults in NYCHA complexes. It's a great question. We are actually working on a maximum temperature policy for the city of New York. We've had a minimum temperature policy in our building code and our administrative code for many years, which mandates, of course, landlords and building owners to keep their buildings heated in the winter. Now we are mandating cooling. We're in the process of working with city council and other legislators to mandate a maximum temperature and mandate cooling. So yes, the answer is we're thinking about it and working on it, but also leaving enough flexibility for building owners to do it the way they need to do it.
Good.
Thank you. Senator Daschle, thank you for being here. You're on mute, I believe.
I'm.
There you are.
You hear me?
Yes.
Yeah, okay. Well, let me join our commission in thanking each of our panel members for your sobering presentations today. We seem to be so crisis response driven in this country. As we look back over all the crises we've faced, most of them we dealt with in response rather than in a proactive way. I'm concerned that we're still not addressing this crisis from a national defense perspective in any kind of a proactive way. And I'm just wondering, I think we look at climate still as a weather issue, a healthcare issue. I don't think we look at it as a national security issue to the extent we need to. I'm just wondering, I've sort of a two-part question. Do you anticipate an inflection point at some point in the future that will drive this to a more of a crisis realization than it is today? And secondly, is there any opportunity as we look at civil defense and national defense to look at whatever technological innovations are underway? You know, we spend tens of billions of dollars on weapons development with technological advancements constantly. I don't think we're doing any of that from a national security point of view when it comes to climate, but maybe I'm wrong. So just that two-part question, is there an inflection point that you could foresee? And secondly, is there a way through national security contexts we could look at technology as part of the solution?
I'll add a couple of things. One is a student and I actually just had a piece in the Hill on 4 value propositions for climate action under the Trump administration, and 2 of them had national security implications. You'll have to read the article for the other 2. But the first was national security. And so there is a strong national security case to be made. To your point, I think that there's a lot more that can be done, but actually for about a decade now, we've been seeing like national intelligence assessments and Defense Department assessments, and they range from things on the implications to defense facilities in the United States as well as in the world and exposure to flooding, I believe that number is around like 20% vulnerable to increased flooding. It's something significant. So I'll have to look it up, the precise number. Increased emissions overbroad due to driven state instability through things like heat and drought and impacts to food systems, as well as increase to the soldiers overseas, right, fighting in different conditions and having to operate in different conditions. And the other is on immigration. A lot of the drivers of immigration that we're starting to see now are more and more sort of having impetuses of things like crop failures, of things like destabilized governments, which are approaching these tipping points where it's not the sole reason. Climate change isn't the sole cause of it, but it's another stressor leading to those tipping points. So I would say I believe we're a lot closer to these tipping points than we think they are. We're a lot closer to these crisis moments, or at least acknowledging these crises as we think they are. And again, this is one where there is some literature coming from these agencies doing this that I would love to see translated into more robust funding and specific programs dedicated to this. But there is some work being done within the existing streams.
If I could just add, Senator, thank you for the question. I mean, you know more than I do. I certainly am not privy to any classified information, but I think it's pretty clear amongst people who do have that access what the prevailing weaponized threats, potential threats are. And it's also becoming clearer who, whether it be state or non-state actors, have those capabilities or are developing those capabilities and how far along they might be. And so that conversation can continue to happen in private, or we can engage the public in that threat assessment and create pressure that way. Yeah. Because I think keeping it to ourselves, let's say in government writ large, but particularly the federal government, and keeping it even to a subset of people in the federal government, you know, I think we run the risk of being too late when we already know we're behind as a country. And so this might be one of those rare examples where you want to have that discussion in public, where you want to actually, because there are many unknowns in how we should build this and respond, and because we're entering an era where it's not clear that we can mobilize the resources to respond, or that there's any interest in doing so. So I do think that more, and you again all know better than me, I think the threats are somewhat known, and yet it's only a select group of people actually having that conversation, and I think we need to open up that conversation much more broadly.
I just want to highlight too that notion of engaging the public early on. So right now, the electoral incentive is on response. There's a very strong voter reward or punishment for the perception of how a disaster was responded to. There's virtually no correlation between preparedness and voter behavior. So what this means is that when it's very front and center, voters will respond to whether or not, to their perception of how well it's being handled, and you can measure that in terms of outcomes. In order to really get to some of the fundamental roots on how do we prompt government action, part of it does come down to rewiring that incentive structure and really asking questions like, why were we so unprepared? And how do we create more sort of signals through our electoral processes to reward investments that actually prevent crises down the road? So I realize I just laid out an entire, I don't know, like sociological agenda that maybe will be the subject of the next hearing.
And I'll just add to it, because I think there's also a communication opportunity here as well. You know, clearly we have got to figure out a better job to cross the divides and the polarization that exists, because as the governor said earlier, people know what's going on around them. You don't have to call it certain labels of things, but people are aware, and actually on climate science communication, specifically at Yale and at GW, there are climate science communication centers, we've seen large leaps in the American population's expression of concern and worry about the climate crisis and climate change, like 25% leaps, almost unprecedented in social science. So there is an awareness. I think there are ways to tie the messaging to the concerns of everyday people, and that hopefully will have a more salutary political tie-through.
Well, thank you all for your very thought-provoking.
May I just add one thing to Mitch's comment? I think it was in 2015, after we put out our blueprint, we had a press conference at the National Press Club, and I think I said, it may be that the voters will not punish members of Congress for not preparing, but they sure will punish them like hell after it happens and they haven't prepared, but they didn't. They didn't.
Senator, did you want to make a comment on their remarks?
No, I was just thanking them and saying that was very, very helpful, Susan.
Thank you. Thank you, very thought-provoking, and I think we're done with this
Yeah,
panel.
well, I think, thank you so much. I mean, I do think you jokingly said topic for the next session, but I think, this was our first real foray into the issues around climate change, health, and biodefense. And I think it clearly is one of the most important issues of our day. It's one where I think our organization and the members of this commission can help to both frame some of the critical issues and concerns, but hopefully also put forward some actionable steps that can be taken. And for me, at least, this day's presentations and discussions were very, very valuable. We covered a whole lot of ground, and I think we're going to have to spend a little time digesting some of what we've heard. We may want to circle back to some of our presenters and track down some of your other works, including your recent Hill article. But we really appreciate the input from this panel and the ones that preceded you. And, I think, that the timing of this is both, a little bit discouraging because we're entering this uncertain period in terms of the political environment in which some of this important work will be done. But I think it's enough of a shared concern of all Americans and citizens of the globe that I think we can and will make real progress. And I look forward to working with all of you as we continue our important work on this. And I encourage you all to continue the work that you're doing every day, because it really does matter. So thank you very much, especially coming out on such a cold and unwelcoming day in many ways. And this session has been recorded. I don't know, will it be posted? And we will make sure that it gets shared more broadly, because I think there are many people who would have liked to have been here that weren't, that will benefit from all of your presentations and our rich discussion. So thank you all very much, and safe travels back to wherever you're going. Thank you.